السلام عليكم.
وعليكم
السلام
السلام يا
عليكم.
دكتور. الصوت واضح، الله يعافيك.
واضح، ممتاز. اوكي، خلاص ان شاء الله نبدا الانترودكشن ان شاء الله على الساعه 3 بالضبط.
ممتاز، بس باقي تقريبا حدود ال7 دقائق الان.
ايوه تمام.
الله يحفظك.
Assalamu alaikum wa rahmatullahi wa barakatuh. I am welcoming you for this course, Multi-Drug Resistance Organism, Challenging Clause. I am Dr. Nashmiya Al-Anzi, pediatric consultant and infectious disease. Our course, it will be 12 hours talking about multi-drug resistance and this multi-drug resistant organism. Today we will discuss about antibiotics groups, some groups, and we will discuss also about mechanism of action and also the types of drugs. And also we'll discuss in the second part about the multi-drug resistance, the definition and mechanism, and also carbapenem resistant organisms, ESBL, and also MRSA, VRSA, and VRE, and all other drug resistance. As you know, in our in the global status, we have increasing. Now we are having increasing drug resistance to antibiotics. We have our job to decrease this resistance. اسمعوني؟ السلام عليكم.
الصوت واضح الله يعطيك يا دكتور.
واضح. اوكي تمام. فاحنا دورنا طبعا في المجتمع يعني the community يعني as a physician, as يعني all the medical staff, and also in the community يعني as a general. دورنا طبعا to decrease the overuse and abuse of antibiotics. This is يعني our job for all of us. فاحنا why in this situation we chose this multi-drug resistant course. Okay, it will be divided. هتتقسم الكورس على 2 days, over 2 days. كل يوم 6 ساعات. As I discussed يعني احنا today we'll discuss about antibiotics types and mode of action. We'll talk first about beta-lactamase. Second, we'll talk about macrolides and also quinolone and the small groups we will diagnose. Now we will start with the beta-lactamase. Will be our speaker, Dr. Tamer Al-Anzi. He is a clinical pharmacist. He will give us talk about antibiotics. We'll start by beta-lactamase. Inshallah, he will give us more discussion about this type of antibiotics. The question, it will be at the end of the discussion, inshallah. We'll start by Dr. Tamer Al-Anzi.
يعطيك العافية دكتورة، بس ثواني الصوت واضح؟
واضح، أنا عندي واضح.
نسوي شير سكرين. بس لو يعطيني الهوست الله يعافيك يا دكتور.
اوكي، ممكن كبر الشاشة شوية معلش.
كذا تمام يا دكتور؟
أيوة نعم واضح.
السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. Thank you very much, Dr. Nashmiya, for this great introduction about the most important topics, in my opinion, which talk about the very precious kind of medications that in the worldwide issue for multi-drug resistance. We are going to talk about in this lecture in my section about antibiotic in general, and then we're gonna take group by group specifically. The learning objective in this lecture would be what is the microorganism, and we are going to talk the various type of antimicrobial, and what we are going to define what the misusing of antibiotics. I'm going to talk as well for the principle of antibiotics and the benefit and risk of antibiotics. And also we are going to describe how to enable to describe the management of infection. And then we are going to the beta-lactams and antibiotic macrolides, aminoglycosides, and quinolones and other antibiotics. And lastly, we are going to talk about management of UTI as an example to how to select appropriate antibiotics and appropriate antibiotics with to cover the most causative organism for the infection. So here in this slide, what is the microorganism? Microorganism is defined as very tiny things that are found all around us and are too small to see by eyes. It used everywhere. Some of them have a benefit for our health, some, and there is a small percentage that can cause an infection, whether that it's bacterial or viral or settings. So the most common type are bacteria, virus, and fungi. There are also microbes called parasota. These are tiny living things that are responsible for diseases such as malaria, pneumonia, and UTI as well. In this slide, we can see the picture here, the orange color, the bacteria in a tip of the. It's very tiny things, and it's about 20 micrometers. So antimicrobial is divided into antibiotics that can be against bacteria. For example, the medicines that you use for urinary tract infection, like trimethoprim, augmentin, or cephalexin. Antivirus against viruses, the medicine used for herbs, HIV, Ebola. And the other one is antiparasitics that used for against parasites. For example, here the medicines that use for malaria. And the lastly is the antifungal against fungi. For example, candida, vaginal thrush, or oral thrush, that's caused by fungals. So how to describe the misusing of antibiotics? We can describe this one by when we use antibiotics are prescribed unnecessarily. In this case, if we talk about the common cold, and as an example, it's a viral infections, and when you use the antibiotics, it will be not do anything. Instead, maybe increase the risk of side effect of antibiotics, or increase the things like resistance. When antibiotics administration is delayed in a critically ill patient. So when the critically ill patients have very severe bacterial infection, and we delayed it as to preserve antibiotics, that is not correct. So the patient with severe bacterial infection has to be immediately taking antibiotics. And also when we use the broad spectrum antibiotics, when we use the antibiotics for the spectrum generously and without identifying the organism to select the narrow spectrum medications. When the dose of antibiotics is too low or very high dose, so the under therapeutic dose or the upper therapeutic dose, that is also misusing of antibiotics. The duration is very important here. When the duration of antibiotic treatment is too short and we didn't eradicate the all organisms, so that can develop resistance of antibiotics. Lastly, when the antibiotics treatment is not streamlined according to the microbiological culture. So usually for the patient come in front of us, we don't know the causative organisms, so that we have to do the empirical therapy for as an evidence for according to the evidence-based, the most common organisms, so we can select the most appropriate antibiotics in according to the most common organisms. And after 2 to 3 days, the culture will be the result will be appear, so we can select the most appropriate antibiotics. So when we look on this slide, the mind principle that I like, so I can it can guide us. It's a bit compromised, but it's just for I'm going to explain every single one briefly. So this slide mind me principle around the antibiotic use, that the idea that whenever possible, first one, whenever possible, use the microbiology guide to select antibiotics. We will come back quite a bit when we start to look at how the antibiotics are initiated to treat the infection, because it's really need additional content. And the other one is indication should be evidence-based. Certainly need evidence-based on everything as a health professional to use the antibiotics and other medicines. So it's very important to indicate it by evidence-based when we select any medicines, particularly for antibiotics or antimicrobials. So obviously we're trying to use the narrow spectrum possible, but that does not mean that all is narrow spectrum. We talk just to find the choice of a spectrum or the choice of the antibiotics spectrums that can cover the causative organisms. So when we use the empirical therapy. So the narrow spectrums, just for select the appropriate medication that can cover most common organisms. And then the dosage appropriate to the site and the type of infections that can absolutely correct. Those is critical things where the for the when we have to ask ourselves first where the site of the infection is, and thinking where the antibiotics can penetrate that site of infection. The error people use to make when the prescriber go to the lowest dose because it's thinking it's safe, but in that case it's not effective. Or there is some cases we have to choose the maximum dose to penetrate the site of infection in accordance with the site of infection. And we have to understand the drug and understanding the risk, what the risk of in term of the dose responsible relationships. and making sure the dose is appropriate for that type of infection. And then the minimizing duration of therapy. Minimizing duration of therapy is not directly like that. I mean here that we have to select the most appropriate duration to eradicate the causative organism that cause infections. So we can minimize everything, every duration of the treatment, but it does not mean that it's, we are on the right track. So we have to make sure we have selected the appropriate duration when we start to initiate the antibiotic treatment. The last one, to ensure the monotherapy in mass situation. When they combine, but here there is some cases the combination is necessary. So we have here we have to ask ourselves why we are using the combination of the antibiotic in this case. What the causes of selection of the combination. So, for example, here we talk about the uncomplicated UTI. Usually we can start with hormone therapy, not the combination. So the infection is not severe, and we select here just one antibiotics. Is that enough and appropriate? So let's go back and talk about the benefits and the risk of antibiotic. I look at the content of the benefit and risk where we're weighing up that obviously in the case of antibiotics, the benefits is clear. The benefit of antibiotics is very clear is to eradicate the causative organism that cause the infection and to cure illness. In the most part, there is some other instance where they're doing something different than that, but in the most part, the intent of the benefit is clear. We're trying to eradicate the organism. So the question here is what the other risk of the antibiotic? Typically, the answer for all health professionals is the resistance, and that's true. We have to be always and mindful of resistance part. But there is other risk. There is other risk for antibiotics, specifically when the patients stand in front of us. We have to consult them about the other risk of antibiotics in a state of resistance. So what the other risk of the antibiotics? Usually the risk of antibiotics, specifically when we talk about the broad spectrum antibiotic, is this disruption of natural flow that can cause by firstly the mild diarrhea, and then it can progress to do a more serious infection, Clostridium difficile, as an overgrowth. It can associate by antibiotic colitis. الصوت واضح يعني.
ايوه واضح الصوت الحين.
So the disturbing natural flora in gastric intestine tract, producing things like mild diarrhea, and can go to the produce more severe diarrhea and cause that antibiotics associated colitis caused by overgrowth CD. So we have to be aware about that and consult the patient that use the antibiotics, specifically when we talk about the broad spectrum antibiotics. And we see other things like for the risk of antibiotics like oral thrush and for women and vaginal thrush as a consequences of this disturbing natural flora. So it's entirely a predictable risk for using the broad spectrum antibiotics. So the pharmacists have a role here to consult the patient what the side effects maybe it will face the patient and consult them how to minimize this risk. And the most things what we have to be concerned as a health professional is resistance to trying to minimizing the misusing that can happen with collaborations between the health professional, the prescriber, and the pharmacist and nursing to select the most appropriate antibiotics and to select the most appropriate dose and also select the most appropriate duration. That can minimize and reduce the antibiotic resistance and to preserve this precious kind of medications to the next generation. And also here there is some drug class specific, for example, allergic reaction and nephrotoxicity and phototoxicity. For example, here when we talk about allergic reaction, that we have to be aware and we are going to talk about in detail. Beta-lactams that can be people can face the groups of antibiotics in a few slides and groups that can cause nephrotoxicity and also the phototoxicity, for example here doxycyclines, and how to consult the patient when you use this medication to avoid exposure to the sunlight. And here, this is slide, we are talking about signs and symptoms of infections. Depend on the site of the site and the severity of infection. Local redness, swelling, pus, and cough, shortness of breath, and then can progress to be systemic, like fever, heart rate, and can impact the blood pressures and the respiratory system. Also, it can cause to maybe impact to the mental status for some kind of infection. I have an example here for UTI for elderly people. It maybe can cause the infection, can cause confusion for cognitively well people, but old people. The UTI can cause confusion for this kind of people. And how to indicate it, that it can be by laboratory test and microbiological show through the urine or swab, and to identify the causes. Also the other things.
الصوت شوية يقطع، معلش ممكن.
الصوت واضح يا دكتورة؟
الآن واضح أيوة، بس أحياناً يختفي.
طيب. بس لو تبلغيني يا دكتورة أول ما يختفي بس عشان يكون واضح. بس عشان
تمام.
So what we have to end up, it's also the white blood cells can give us an indication that patient have an infection. So how to manage the management of infection? The first thing we have to ask ourselves questions so we can go to trying to select the most appropriate. So if the patient have suspected or established infections, if no, maybe we can go for the prophylaxis for the people who have some kind of medical conditions. So the patient had infection, suspected infection. So ask the question is the causative organisms known? So in most part, when the people come in front of the prescriber or doctors, we don't know the causative organisms. So here we go to the empirical therapy. For the selection empirical therapy, we are going to select the most causative organism on that side of infection. In according to the studies and absolutely according to the evidence-based and once we know the causative organisms after the blood result or the urine culture, we select the narrow spectrum that can cover this this causative organism that cause the infections. So obviously the laboratory tests have the role here to try to work out to select the causative organisms. So, as we said, the laboratory tests have a role to work to find out the causative organism, but this this process take time. So we don't get the answer straight away, taking some days to growing up and determine what is the causative organism. But it has provided very useful information to identify the antibiotic sensitive. So looking at this slide is talking in details what we speaking of previously in the last slide. So antibiotic choice has to be based on demonstrating microbiology by antibiotic sensitive. Antibiotic choice should be narrow spectrum drug to which the organism is sensitive, and at least toxic and convenient treatment. Once we get the result and identify the causative organism, the directed therapy should be narrow spectrum drug which the organism is sensitive and least toxic and that more convenient to the patients that can help the patient to be compliant for the medication and complete the dose. For empirical therapy, the antibiotic choice should be based on the most likely and important and potential pathogen, and they're likely the antibiotic sensitive. So the empirical therapy we're trying to when we use the empirical therapy, we're trying to use the broad spectrum as we can, because we don't know the causative organism, but we are based on the study and our experience to know the most causative. So we're trying for very ill patients. We have to try to select the broad spectrum that can eradicate the causative organisms. The causative that cause the infections. So to cover everything, the problem here, maybe we're running the risk of building up the resistance of antibiotic and getting the side effect. But in reality, the most people, they have the infection and they caused by the most likely cause. So the empirical doesn't necessarily mean that very, very broad. We're just trying to cover the most likely organs. Once we know the organism, then we go to the direct therapy and select the narrow spectrum as we can to cover that organism. So the selection of antibiotics should be based on should be based on so the selection of antibiotics, the pharmacists have to cooperate with the prescriber to select the most appropriate antibiotic that can cover that organisms. So how do you know the most likely organism? Do you know the site of initial infection? What the common organism for that site of infection? Could be caused by normal flora overgrowing or moving to the other sterile area. For example, UTI and cellulitis. Could be by knowing foreign organism, for example, a dog bite. That's before we initiated for using antibiotics. So this question can help us to select antibiotic that can cover the causative organism of infection. So the other thing, are there other factors that can change the type of organism? For example, is the patient have any other comorbidities? Or if the patient is immunocompromised? Does the patient have anatomical abnormalities? And we have to ask, where is the patient being? For example, traveling overseas or the patient in hospital. So for the patient have immunocompromised, the immune system does not fight the organism properly. But and that can cause maybe exposure to a wide range of organisms. So here, when we compare it to the normal people, we have to use for these kind of patients very broad antibiotic, broad spectrum of antibiotics to trying to cover all the organisms that may cause the infection. When we ask where is the patient's where is the patient's being, traveling overseas for example, in our country, and traveling to the different area in different part of years, that can exposure to the because the weather can maybe exposure in different organisms. If the patient in hospital, we have to ask which part in the hospital the patient's being. For example, intensive care units, where the patient's been using broad spectrum that can develop the resistance of antibiotics. And we have, if the intensive care unit, so we have used that broad spectrum to try to cover all the organisms until we get the result from the microbiology test. So we get start to the classifications of antibiotics. It's classified in according to here in this slide and these few slides, in according to their mechanism of actions. For example, here inhibit bacterial cells wall, for example, beta-lactams, penicillins, cephalosporins, carbapenems, and also vancomycin. And there is antibiotics that inhibitor of protein synthesis, liposomides like clindamycin, macrolides like azithromycin, chloramphenicol, aminoglycoside, and tetracyclines. That mechanism of action, their mechanism of action is inhibit protein sensitive and kill the causative organisms. And also there is other type like quinolones and rifampicin and sulfonamide trimethoprim. Their mechanism of action, for example, the quinolones inhibitor nucleic acid synthesis and trimethoprim inhibitor of metabolic pathway like antagonist. So the beta-lactams is classified to penicillin, for example, amoxicillin, and we are going to in details for each part of these medications, but correlated thing between these kind of group is the beta-lactam rings, and that's important because it tells us if the patient have hypersensitive for some medications can be lead to the cross-reactivity to the other group. For example, if we have patient have immediate hypersensitive reactions when you use the penicillin, we cannot use as alternative cephalosporin, or because it may lead to the same reactions because the rings of the beta-lactams here, this chemical structures. So the first part for beta-lactams we are going to talk about is penicillins. For example, here amoxicillin with the clavulic acid, and anti-pseudomonas, penicillin, piperacillin, tazobactam, and also the other one is fluoxetine, doxycycline, and the other thing is natural penicillin. For example, penicillin G and benzethine penicillin. The mode of action of these kind of medication group is bactericidal, interfere with the bacterial cell wall, peptide glycan synthesis by binding to the penicillin binding, and that eventually lead to cell lysis and the cell death. What we have to be precautions about this kind of medications that's very common is allergy. So the patient, if we have patient in front of us, maybe this is the first question we have to ask about. Do you have any allergy of any kind of medications? And we have been asked them specifically if you do have penicillin allergy or something like that. And after that, we can ask another question like what kind of allergy that you have. If it's immediately or delayed reaction, that can affect to the decision making. So the precaution here, the allergy, the penicillin is contraindicated with the people have a history of immediate bronchospasm, anaphylaxis, or severe interstitial nephritis, hypersensitive to the penicillin. Also, for the people have rash from ampicillin or amoxicillin are often not immunomediated. We have to consider testing for the penicillin hypersensitivity before giving any other penicillin. So we have to be careful if there is carbapenem or cephalosporin allergy as a cross-reactivity, as I said before. Maybe cross-reactivity reactions can be occurred with because the beta-lactam ring that connected with these kind of group medications. People with the renal impairment, the high parental doses and prolonged maybe result in electrolyte disturbance due to their sodium content. So we have to monitoring the electrolytes for people using this kind of medications for long term and with high dose. And also can cause the nephrotoxicity due to the accumulations of penicillin. And that can be, for example, seizures or coma. And also for the people with renal impairment have a risk of neutropenia. So we have to be monitoring thoroughly and continuously monitoring for people using penicillin for long term with high dose.
Dr. Tamer, remaining 15 minutes for to conclude this topic.
Okay,
for you? Okay.
15 minutes.
15 minutes. 4 o'clock we will go for.
Okay. ممكن نخلص البنسلين. ممكن نخلص البنسلين بعدها ناخذ بريك.
اوكي تمام. For prayer break.
Okay. So what's the common adverse effect of penicillins? Penicillin are generally well tolerated. It's not that kind of risk medications, but the risk here is we have to be aware is the allergy. And the other thing is diarrhea and nausea. Diarrhea, and we have to be mindful about that. Maybe if we use the broad spectrum antibiotics, that can cause mild diarrhea, and we have to be aware to not progress to be severe diarrhea and cause cholesterol and that. So maybe it can cause the pain and inflammation at the site of injection. and can be as super infections, including candidiasis, especially during the prolonged treatment with the broad spectrums. So there is an administration advice of when we taking penicillin. We have to avoid rapid IV administration for large doses, as it can cause seizures. And IV penicillin are physically and chemically incompatible with the many substances like aminoglycoside, for example, here gentamicin. So we have to be aware to take them separately. And we have to monitor complete blood count and renal and hepatic function during the prolonged high-dose treatment for more than 10 days. We have to avoid the penicillin and cephalosporin in the presence of the ESCA-PKM group organism, enterobacteria that can produce, and also enterobacteria that can produce new delta beta lactams. So on this slide is a comparative information between the different kind of the penicillin medications. They are different in spectrums, and some of them have a narrow spectrum, some have direct spectrums, and some of them have broad spectrum. So those with moderate and broad with the anti-pseudomonal spectrum have additional and increased activity against gram-negative organisms. The narrow spectrum, the actively primary against the gram-positive organism, and usually susceptible to the beta lactams, and usually inactive against the enterococcus due to the low tissue concentrations. The moderate spectrum, the amoxicillin and the ampicillin, are interchangeable. So if we don't have the ampicillin, we can use the ampicillin as the alternative. However, there is no oral ampicillin as an oral product. They are inactivated by beta lactams and are active against Listeria, gram-negative cocci, and some gram-negative bacilli. For example, here beta lactam is producing H. influenza, as well as many E. coli and Salmonella and Shigella. The broad spectrum, when we add the clavulanic acid to the amoxicillin or tazobactam to the piperacillin, extending their spectrum of activity to cover many beta lactams producing gram-positive and gram-negative. With the clavulanic acid, amoxicillin spectrum includes species such as E. coli and Klebsiella. So, and with the tazobactam, piperacillin is active against Pseudomonas and Klebsiella pneumoniae. وصلنا للبريك يا دكتورة ولا نكمل؟
10 minutes. 10 minutes left.
10 minutes?
Yes.
So we talk in general in penicillin and what the difference between the type of the medication of these groups and how they cover the organisms. And the next one, have to go to the cephalosporin. And cephalosporin is can classified through the first and second and third and fourth generation, for example, for the cephalaxin, cefazolin, cefidim, cefotaxime, and ceftazidime, and ceftriaxone, cefixime.
We can allow a question from the audience.
For the first part that we talk about, though?
Yes. Any question from the audience, please type it in the chat. واحد من الاودينس asking about ليش ما ينعطى الأمبسلين مع السيفازولين؟ You mean ampicillin with the cefazolin or ceftriaxone or what? Ampicillin with cephalon. You mean ampicillin with cephalon?
Ampicillin with?
Cephalon. You mean cephalosporin, sorry.
As a combination يا دكتورة معلش؟
Yeah.
السؤال يا دكتور مو واضح معلش
السؤال هو السؤال سائل ليش ما ينعطى الأمبسلين مع السيفالو؟
For selection the antibiotics we have to be just aware about what the kind of infection that we have and what the causative organism that we have to cover. So the combination of penicillin and cephalosporin, all of them is considered a beta-lactams, and maybe it's not that will increase the risk of side effect and maybe increase it will be not the covering of all causative organisms. So, if we use the penicillin or cephalosporin, it's going to be the same. So the combination and also the beta-lactam strains and consider they are in the same group. So we're not using in the same group as the beta-lactams, penicillin and cephalosporin.
You mean both they are covering same organism group or spectrum, so no benefit to combination of both antibiotics. Still MDRO after the second break. Okay, Dr. Thamer, you want to start cephalosporin after break?
خلينا ناخذ بريك يا دكتورة وبعدين نبدأ بالنكست سكشن.
اوكي بريك حيكون من الساعة 4 لحد الساعة 4:30. في أي سؤال قبل لا نغادر الجلسة؟ أوكي، نجتمع إن شاء الله مرة ثانية على الساعة 4:30 بإذن الله. مع السلامة. Assalamu alaikum. Welcome back after prayer break. دكتور ثامر معنا؟ سمعنا في الجزئية الأولى about mode of action of antibiotics, site of action, and the empirical therapy. And we talk about first class of antibiotics, beta-lactamase. First class we discussed about penicillins. We'll continue cephalosporin. دكتور ثامر معنا؟
اي الله يعافيك، الصوت واضح؟
واضح.
طيب خلينا نسوي شير سكرين بس يا دكتور، الهوست معك ولا معي؟ بسم الله والصلاة والسلام على رسول الله. بس بناخذ ريكابينج على first part of antibiotics. We talked about the penicillin and we discussed about the mode of action, the risk, and the common side effect. And some practice point, what we need to monitor when use for penicillin for long term. Now we are moving on to the cephalosporin. We do have various type of medication of cephalosporins. And as an example for cefotaxime, ciprofloxacin, ceftazidime, and ceftriaxone, cefepime. The mode of action of these kind of medication is interfere with bacterial cells wall, peptide glycan synthesis, and then binding to the penicillin binding protein, and that eventually leading to the cell lysis, and it's considered as a bactericidal. So usually the indications of these kind of group cephalosporin are rarely the drug used as a first choice. We do have an exceptions here, including ceftazidime and cefepime can be used as a in the febrile neutropenia, and the cefotaxime and ceftriaxone with the benzyl penicillin can be used as for the empirical therapy when we treat the bacterial meningitis. We do have as the penicillin because they are considered all of them beta-lactams group. So we do have precautions when we use this medications. It's like the penicillin, cephalosporins as contraindicated with the patients who have immediate anaphylaxis. We use this medications like bronchospasm and severe intrastatal nephritis. So we have to be careful also here when we use the cephalosporin. If there is a carbapenem or penicillin allergy, maybe can cause a cross-reactivity between these group for the patient who have immediate hypersensitivity. For the renal impairment people, for the dose cephalosporin, maybe it's needed for reduction dose when we use it for the people who have a renal impairment, because that increases the risk of neurotoxicity such as seizures and coma, especially when we talk about the high doses risk that can increase the risk of neutropenia and maybe increase the risk of these side effects. The cephalosporin here, when we talk, it's considered a safe for pregnancy, and in breastfeeding also is safe, but maybe can cause loss of bowel action in child. There is no data for the breastfeeding and pregnancy for ceftaroline and ceftazolam. What is the common side effect of these medications? Usually, when we use the antibiotics, most probably the common side effect is diarrhea and vomiting and nausea. Also, the pain and inflammations. It's typically like the penicillin, the pain and inflammation on the site of injection. Sometimes we have the rash and dizziness and headache for people. But we have to be aware about that spectrum of these antibiotics. Maybe can lead to the mild diarrhea and then progress to the severe diarrhea, and we end up to the Clostridium difficile associated disease. For the immunological reactions for cephalosporin may include encephaly, and drug fever, anaphylaxis, angioedema, and hemolytic anemia as well. As we said, when we use the cephalosporin, we have to be, especially for the people who have renal impairment. Again, we have to be, sometimes maybe it's required to reduce the dose. We have to be balancing between the benefit and the risk. So if we have the benefit of increased dose, or maybe for the renal impairment people, we need to bear in mind those reduction for the cephalosporins. So when you compare between the different medications of the cephalosporin, the cephalexin and cefuroxime are only type of the cephalosporins and cefaclor, only type of the cephalosporin that have available as oral product. For the spectrums, all have the central beta-lactams ring structure, and it is a side chain determined antibacterial pharmacological and pharmacokinetics properties. The moderate spectrum include the cefaclor and cefuroxime, cephalexin, and cefazoline. They are usually against staphylococci and the streptococci, and some gram-positive anaerobes are also sensitive for these kind of indications. They have poor activity against the gram-negative bacilli, although some strain of E. coli and Klebsiella. For the broad spectrum for this kind of medications include cefepime, cefotaxime, ceftazidime, and cefazolam with the tazobactam and ceftriaxone. Cefotaxime and ceftriaxone and cefazime have less gram-positive activity, but are more stable with the gram-negative beta-lactams than moderate spectrum cephalosporin. They are active against many gram-negative organisms, resistance to the other beta-lactam drugs. In this part of group of medication, we have to be aware for the cefotaxime and ceftriaxone. They have equivalent efficacy and safety in most indications, and ceftriaxone requires less frequent dosing, so maybe more convenient than cefotaxime. Also, for the neonatal patients, the ceftriaxone is not preferably used. We use as alternative cefotaxime, that because maybe can the ceftriaxone replace the bilirubin and cause maybe a side effect for hepatic functions. So for neonatal, we don't give him the ceftriaxone, we give him that and stay the cefotaxime. Cefotaxime is prepared to ceftriaxone for gram-negative cytopenia in neonate, as ceftriaxone is displaced bilirubin from albumin, and that can increase the risk of bilirubin encephalopathy, and consequently it is contraindicated in the preterm neonate and post-menstrual age of 40 weeks, and full-term neonate with jaundice or other condition that may affect the bilirubin binding. The other class here is the carbapenems. For example, here imipenems and meropenems. The mode of action for this class is to inhibit the bacterial cell wall synthesis by binding to the penicillin binding protein, and the affinities for which differ between the carbapenem and may affect their activity. And it is usually bactericidal for this kind of group of medications. There is some precautions for using the carbapenems when we treat the people they have using the sodium valproate. It maybe can affect to their concentration, whether that valproate or the antibiotics have been used. In a pregnancy, for this kind, there is a limited information when we specifically for itrapenem. There is limited information, so maybe we try to other kind of medication groups that more safer if they can cover the most common causative organism for that patient. The most common adverse effect of these groups, the neurotoxicity, specifically for when we talk about imipenem, is associated with neurotoxicity, such as confusion, seizures, and coma, especially when excessive doses are used in people with the CNS disorder, or with the people with the renal impairment. Maybe that can increase the risk of this side effect. Nausea and vomiting also is very common side effect for this group, and usually as those related with especially with imipenem, there is a high incident for incident with the rapid infusion, maybe the rapid infusion used the imipenem maybe can increase the risk of for the patient to have side effects or nausea and vomit. What is the practice point when you use the carbapenems groups? The carbapenems are particularly useful when a single agent treatment is required for complex mixed infections. Otherwise, the combination of the medication that less expensive, that we talk about the cost and economy, maybe provide antibacterial cover and clinical effects. If we talk about it specifically, because it's very common use, the meropenem. The meropenem is indicated to be used for various type of infections as empirical therapy. For example, here maybe can use for as empirical therapy for multi-resistance gram-negative infections if suspected or proven. We use directly as empirical therapy meropenem, and also can use for nosocomial infection and life-threatening infections when other antibacterials are inappropriate or contraindicated. One of the adverse effects of the meropenem is thrombocytosis and raise of serum aminotransferase bilirubins. Also, there is some adverse effect like seizure and the thrombocytopenia and neutropenia, and maybe can cause multi-organ hypersensitive syndromes. As we said here, as a practicing points for the carbapenems, the carbapenems are particularly useful when the single agent treatment required rather than combination therapy for complex and mixed infections. One of the points of imipenems should be infused for 250 to 500 mg doses over 20 to 30 minutes, and 1 gram doses over 40 to 60 minutes to avoid the side effect that's related for these medications. Avoid the side effect like nausea and vomiting, and this is not to avoid the inconvenience for patient when using this medication. So now we move on to the vancomycin, which is one medication that usually the hospital in our country make a restriction because it's related to some side effects. So the patient has need to gradually monitoring them when they use these medications. The mode of action of the vancomycin, it is bactericidal, inhibit bacterial cell wall synthesis by preventing formation of peptide glycan polymers. The indications for vancomycin, used for MRSA. That's very popular indication for and endocarditis prophylaxis in the penicillin allergy, and used for severe infections caused by organisms in case of penicillin resistance or intolerance of meningitis or endocarditis with other agents. It also Clostridium difficile can be associated as indication. Clostridium difficile associated disease. Vancomycin can be used in this case, one of the options, but it's usually in this case used as oral, not as IV, because it's for this kind of medical condition. When we have the patient, we need the action of this medication to be in the GI that we aim to do. So it's one of the options to treat the Clostridium difficile as oral. It also uses antibacterial prophylaxis for endocarditis before the certain procedure in the penicillin hypersensitive people at high risk. Use a surgical prophylaxis for major procedure involving in implementation, for example, cardiac and vascular procedures with the people with high risk of MRSA or MRC. One of the adverse effects of the vancomycin, when you use it orally, it's vancomycin maybe can cause indigestion and nausea and vomiting and chills as well. We have to be precaution for allergic when we use the vancomycin, precaution about allergic cross-reactivity between vancomycin and tibiclopinin, because it's been occurred in inflammatory GI conditions, and maybe allow the significant oral vancomycin absorption, increase likelihood of adverse effects, especially in the renal environment. So in the renal, increase the dose interval or reduce the dose in both renal impairments. Some of the precaution we have to be aware in the elderly people, because it can increase the risk of toxicity. So the precaution here, the serious allergy, particularly with the glycopeptide, it's contraindicated. Hearing environments, maybe increased risk when we use the vancomycin with other medication that have the same risk to cause the ototoxicity, like aminoglycosides, for example, here, gentamicin or amikacin. So one of the things that we have to be cautious and mindful about the concentration monitoring. So usually after using the patient who's on these medications, the prescriber required or the pharmacist can be requested concentration monitoring for people they are on this medication. So when we give him that with aminoglycoside or any other nephrotoxic medications, or even when we use the vancomycin alone, we have to be monitoring the renal function, and maybe can be affected after using these medications. Also, where the pharmacokinetics are altered, for example, with the patient who has burning patients, who has or any other morbidity like obese patient, that can cause changing of the pharmacokinetics of this medication, and maybe require higher doses, or for the patient who where the patient is being changed for pharmacokinetics. So maybe it's required to increase the dose, or maybe we have to bear in mind the changing of the clearance of medications. For during high dose and prolonged treatment, when treating infection due MRSA with heterogenesis or susceptibility. Also, here another thing is that we have to be monitoring the concentration in patient when hemodialysis receiving one dose of vancomycin can change the half-life, varies according to the ultrafiltration rate of dialysis porcine. For the therapeutic range of vancomycin, for twice daily dosing, the trough level should be 10 to 20 mg per liter, and that can be the first sample. The samples the first sample take just before the fourth dose, and the trough less than mg per liter minimize resistance to developing, but but may increase the risk of nephrotoxicity. So here the trough level, if it's more than or less than 10 mg, can minimize the resistant development, but can increase the risk of nephrotoxicity. And here we have to balancing the risk outweigh the risk and the benefits. So the benefit outweigh the risk. So maybe can use this trough, or if the risk it's being outweighed the benefit, maybe can not use this trough of when we use the therapeutic range. There is some guideline that recommended the trough level should be from 15 to 20 mg per liter based on susceptibility of pharmacokinetic and pharmacodynamic data and the clinical experience to treat the serious infections. But the higher doses required may result in increased adverse effect. So here also we have to, when the prescriber making a decision, you have to be balancing the benefit and the risk, whether the benefit is outweigh the risk or not. The administration advice for vancomycin, it's given it for over 16 minutes at least. And the rate maybe is not 10 mg per minute for doses more less than 50 mg. So what's the practice point for vancomycin? The practice point for vancomycin, the beta-lactam is preferred to treat methicillin susceptible Staph aureus infections. And vancomycin may be less effective in that case. Used with aminoglycosides for serious enterococci infections, but the combination here it can increase the potential nephrotoxicity. So we have, for example, in that case, we have to truly following the renal function for the patient using two medicines that have a risk of nephrotoxicity. I'm not sure if you do have any question on this part. Is there any question regarding to the vancomycin? So the vancomycin is very important medications that we have to be mindful when you're using it to preserve it and not make preserve it for to treat the very critical infections. So when we misusing this kind of medication, may that increase the resistance of these medications, and we lose the benefit of the vancomycin and other antibiotics. So now we move on to other type of other groups of antibiotics, aminoglycoside. For example, here the amikacin, gentamicin, streptomycin, tobramycin as IV, and oral promomycin. The mode of action of the aminoglycoside is inhibit protein synthesis by irreversible binding of 30S ribosomal subunit, and that causes cell membrane damage. It is a concentration dependent concentration dependent bactericidal effect. One of the risks here, it's correlated when we talk about aminoglycoside and vancomycin for ototoxicity and nephrotoxicity. So we have to be aware of these kinds of medications for the patient on aminoglycoside or usually these kinds of medications are restricted according to the guideline the hospitals in our country. So with the precaution of using aminoglycoside, here we have a precaution when you use the gentamicin or amikacin or any other type of aminoglycoside. The allergy for this kind of medications and also for the ototoxicity patient, it's contraindicated in people with history of vestibular or auditory toxicity caused by aminoglycoside before. So before we give in the patient, we have to be aware of the patient medication history and with the side effect that it has before using these medications. Also neuromuscular diseases, aminoglycoside can increase the risk of muscle weakness and respiratory depressant. If we use the amikacin in a pregnancy case, the bromacin and the streptomycin are there are no data available, but we use for pregnancy, use the amikacin and gentamicin or tobramycin in pregnancy. Those not appear to be associated with increased risk of malformations. If the prescriber have no choice to use, we have to be aware when using this group of medications. But there is no data for amikacin and gentamicin, tobramycin to increase the risk of malformation. There is 2 cases of in studies the renal abnormalities have been reported when the gentamicin was used with the ciprofloxacin and the corticosteroid in the first trimester. So we have to reserve it for the severe life-threatening infection, for which in a pregnancy cases, for which safer drug safer drug are inappropriate. We preserve the gentamicin aminoglycoside amikacin. And breastfeeding is considered safe. For elderly people, we have to use it with cautions, as they are more likely to be pre-existing renal and hearing impairments. One of the precautions of aminoglycoside for neuromuscular block, it may result in respiratory depression and can usually be reserved with the prompt administration of IV calcium gluconate. And the effects of newstigmine is variable here. Here in this table, this slide here, the tables can be considered a comparative information regarding to the side effect of using the different aminoglycoside. For example, here in neuromuscular blockade, the streptomycin is being more powerful in that case when you're comparing to the gentamicin and the amikacin or tobramycin as well. And here for maybe you can see the side effect of vestibular toxicity. For the streptomycin, it's been more powerful when we compare it to the other, but the amikacin here, it's considered more safe than the streptomycin and gentamicin and tobramycin. It's like a comparative information between these kind of group of medications. For concentration monitoring, usually for treatment less than 48 hours, the drug concentration will be not necessarily, but the people use with more than 48 hours, we have to follow and monitoring and check the renal function of that patient who use this medication. And we have to measure the drug concentration and measuring serum creatinine every 3 to 5 days in clinically stable patients. The result obtained daily if the clinical state, especially renal function, is if it's unstable, considering use alternative agents. So usually in some hospitals making restrictions for using the aminoglycoside if it uses for more than 48 hours, they auto stop this medication until get justifications from prescribing, and they monitoring the kidney function for patients who use more than 3 days or 2 days on gentamicin. For once daily dosing, the method for monitoring drug concentration include graphical trough plasma concentration and the target AUC. Although no method is proven to be clinically superior in AUC or the trough plasma, but usually we use the graphical trough plasma concentration rather than AUC. This is required if we want to monitoring the concentrations. It's required 2 samples. Collect the first about 30 minutes after completing the collect the first one about 30 minutes after the completing the infusion or injection. And the second one is after 6 to 13 hours later. So it's required 2 samples to collect the first about 30 minutes after the completing infusion, and the other one is after 6 to 14 hours later. It is estimated 24 hours. And عفوا. معلش على التأخير عذرا. So the estimated is 24 hours AC. It's generally calculated through the computer program. If you do have any question about this kind of a group, because it's very important to be understood and to be follow the concentration and monitoring for the patient using this kind of medication. Do you have any question? So there is no question about aminoglycoside and the concentration monitoring about this kind of medications. So now we move on to the quinolones. For example, of this kind of group, the quinolones, ciprofloxacin, norfloxacin, and ofloxacin, and moxifloxacin. For this kind of a group is in the worldwide resistance to the quinolones is increasing. So we have to be aware and following the using of this group appropriately and for the appropriate patients. The mode of action of the quinolones is bactericidal that inhibit the bacterial DNA synthesis by blocking the DNA lysis and tuberculous IV. For the indication of the quinolones, it's reserved for proven or suspected infection where alternative agents are ineffective or contraindicated. For example, here, when we don't have any other choice, عفوا. عذرا على المقاطعة بس ظهرنا طولنا بالكلام كثير. So the indication of the quinolones here, it's usually preserved for proven or suspected infection where the alternative medications are ineffective or contraindicated. For example, here for UTI, we are going to speak about this medical condition and how to select the quinolones instead of the other antibiotics. So this kind of medication is the worldwide resistance increasingly happened. So we have, as a health professional, to be mindful about that and preserve it to most serious infections when we do have the contraindicated contraindicated or contraindicated antibiotics or suspected infection where the alternative agent is ineffective. So what the precautions that we have to be aware about this kind of medications? The quinolones are associated with some serious neurological adverse effects, for example, here, peripheral neuropathy. So avoid use it in the people with the history of they have a peripheral neuropathy. Also, when you speak specifically for ciprofloxacin, maybe it can cause a tendon damage, and use caution if there any history of tendon damage from quinolones. So the patient medications history, it's very important before the using of any medication, and particularly for the antibiotics. So that's the role of pharmacists. They have to be aware of this, to ask the patient what the medication that has been on, and what if there is any other any side effect that the patient has been experienced when you use the antibiotics. For example, if the patient have the tendon damage when he be using the ciprofloxacin as an example. So maybe we will not dispense it. We use that alternative medications to avoid that side effect. So other risk factor for using quinolones may include the kidney and the heart, or or renal impairment, rheumatoid arthritis, and hyperthyroidism, and musculoskeletal disorder, and also maybe the risk factor of diabetes, and diabetes in being an athletic trainer. For children, the damage, the tendon damage, damage of grown cartilage has not been demonstrated in human due to the quinolones used at a similar rate in the comparator groups as a study. The quinolones are recommended for use in children and adolescents only in severe infection, where the benefits outweigh the risk of arthropathy, for example, febrile neutropenia, or in cystic fibrosis. So in children or adolescents, we try to avoid it and preserve it for severe infections, and with the benefit outweigh the risk for the patients. And we'll be cautious about the side effect of these kind of medication. One of the common side effects of quinolones is rash and itchiness and nausea, and also vomiting and diarrhea, as similar to the other type of antibiotics. Infrequent side effects like headache, dizziness, insomnia, and depression, and myalgia and tendinitis. For comparative informations, when we talk about the comparative information between the quinolones have an excellent activity against H. influenza, enteric, and other gram-negative bacteria. For example, Pseudomonas aerugans. They have some activity against the gram-positive bacteria and include limited cover against MRSA. However, due to the potential for rapid emergency of the resistance in MRSA when treated with the quinolones, these drugs should be avoided in such infections. Ciprofloxacin and norfloxacin and ofloxacin have limited activity against anaerobic bacteria. If we do have any question about this kind of groups, before we move on to the microlight.
السلام عليكم دكتور تامر.
سلام. هلا يا دكتور.
دكتور تامر، بالنسبة للسيبروفلوكساسين والكينولونز استخدامهم في البيدياتريكس في الأطفال، يعني بعض الناس بتقول إن هم ممكن يستخدموا في ريفرنسز بكده، وفي بعض الناس بتقول إن هم كونترا انديكيتد، فلو تدينا يعني هنت عن
هو قلنا يا دكتور احنا الكونيلونز سيبروفلوكساسين we have to preserve it for the patients, children with adolescents, الأطفال, preserve it للسيفير infections. إذا كان severe infections والbenefit هنا outweigh the risk، لأنه ممكن يسبب damage للكارتلج and affect المصل للشلدرن. ما ادري انا جاوبت الجواب الكافي دكتور ولا؟
يعطيك العافيه دكتور.
الله يعافيك. Any other question for this kind of So now we move into the macrolides. For example, for this group, azithromycin, clarithromycin, erythromycin. The mode of action of these groups is bacteriostatic, inhibit bacterial protein synthesis, and that can lead to eventually to by binding to the 15S ribosomal subunit. The indications of these groups is a treatment and prevention of infection due to susceptible bacteria, including using in the penicillin or the cephalosporin allergy. So maybe one of the alternative, use this group as alternative when the patient have a penicillin or cephalosporin allergy. So when we talk about the adverse effects, commonly we usually the GIT should be involved, nausea, vomiting, and diarrhea. Abdominal pain and maybe can cause cramps, the painful in the abdomen, and cause candidal infections. There is infrequent side effects like rash or headache, or rare side effects like hypersensitivity and Stephen-Jones syndrome, psychiatric disturbance. Maybe it's one of the side effects, but it's considered a rare side effect. Ototoxicity and tetanus and dizziness and hearing loss. When we compare between this kind of group, the erythromycin has higher incidence on GI adverse effect comparing to the other kind of comparing to the other medication in the same group, like azithromycin or clarithromycin. There are more drug interaction with the clarithromycin and erythromycin than the azithromycin and roxithromycin. This is as a comparative information between the same medication in the same groups. So we do have the erythromycin higher incidence to cause the GI side effect, and comparing to the other medications. And there is a drug interaction when we with the clarithromycin and erythromycin, comparing to the azithromycin and roxithromycin. Erythromycin and clarithromycin can increase the QT interval, so we have to be aware about the patient who have any medical conditions related to the heart rate or something like that. And cause prolonged QT. Azithromycin and roxy have been associated with the same adverse effect in related to the QT interval. For this reason, we have to be for the patient being admitted in the hospital and using this medication, especially when we talk about the children, we have to be aware about this kind of side effect. And one of the adverse effects is azithromycin and erythromycin are associated with the development of infantile hypertrophic pulmonary stenosis, and the risk is higher when with the erythromycin than the azithromycin. So for azithromycin, I'm going to speak in details for this medication. Using it for, there is limited data for using it with children less than 6 months, especially in a neonate. However, it has been associated with infantile hypertrophic pulmonary stenosis. For a practice point for macrolides, there is often a cross resistance between macrolides and linocosomide, like clindamycin and linomycin. The immunomodulatory and anti-inflammatory effect of macrolide are used in diffuse bronchiolitis, where the improved lung function has greatly increased survival. Cystic fibrosis, where azithromycin may be helpful of help improving or maintain the lung function and decrease the number of antibacterial courses. However, with the long-term treatment of pulmonary function may be again deteriorated, and macrolide resistance being maybe it's occurred. Although inactive against Pseudomonas aeruginosa, macrolide reduce the biofilm for reduction of mucoid strain and also inhibit some virulence factors. This may be contributed to their effect in cystic fibrosis and diffuses the bronchiolitis. We do have any question of macrolides? We talk about this group in general. We just speak about mode of action and the common side effects and what we have to be aware. If we go into in detail, it will take very long time. We just going through the example of the group of macrolides and the mode of actions and some indications and what's the common side effect and what's the practice point that we have to do if the patients using these medications. There is any question regarding to the macrolides? Do we have any question about that? So now we move on to the rifampicins. Rifampicins, rifabutin, rifampicin, and rifaximin. The mode of action of this kind of medication is the bacterial inhibit the bacterial iron polymerase. Rifampicin and rifabutin are bactericidal against rapidly dividing tuberculosis and active against those which are semi-dormant intracellular organs. Rifaximin has a local effect on E. coli that cause diarrhea and GI flora that produce toxin and that cause encephalopathy. Usually using this rifampicin in infection like tuberculosis, one of the medications indicated to use in these medical conditions.
Dr. Samer, can you conclude because we have 5 to 10 minutes for prayer?
Okay. So the most common side effect for the rifampicin is GI symptoms like vomiting, nausea, and cramps, and maybe it's a rash. In a pregnancy, the rifampicin is considered safe during pregnancy, one of the drugs recommended to treat tuberculosis during the pregnancy. However, use in the last few weeks of pregnancy can give we maybe should to give the prophylactic vitamin K to the mother and to the neonate as a bleeding attributable to the hypoprothrombonemia has been reported in a newborn and in the mother after using the pregnancy in the late or in the third trimester. So as a for the pregnancy woman, we use the if she using the rifampicin, maybe we give him as a prophylactic vitamin K for the mother and the neonatal baby. معنا وقت دكتور نروح للنكست سلايد ولا ناخذ البريك؟ So we move to other antibiotics. For example, here is linezolid. Linezolid is indication for the serious infection due to the gram-positive organism where the other agents are unsuitable. For example, vancomycin resistance enterococci. So this kind of medication, linezolid, is used as alternative when we do have a resistance of we do have the patients have a resistance on the vancomycin, we can use it as alternative. And this considered the last medications that we talk about. And maybe we can take a break for a prior break, and then we maybe can continue to start the second sections of this lecture with the Dr. عاطف إن شاء الله. دكتورة نشمية تسمعيني؟ الصوت واضح ولا في إشكالية؟ دكتورة نشمية؟
دكتور تامر، ان شاء الله بريك للصلاه ونرجع.
بريك الصلاه وراح نبدا
6:15 ان شاء الله.
6:15 ممتاز. راح يبدا السكشن الثاني دكتور معك بعد الصلاه ان شاء الله.
ان شاء الله 6:15.
Thank you very much for your listening, and maybe we're going to be back ان شاء الله بعد الصلاه باذن الله. راح يكون معنا الدكتور عاطف يتكلم عن الأذر بارت للليكتشر إن شاء الله. شكرا لاستماعكم. إذا في أي سؤال يا ريت تكتبونه على الشات إذا نقدر نجاوب. In regarding to the antibiotics in general أو إذا إن شاء الله راح نتكلم إن شاء الله بكرة عن example لليو تي آي وال some infections اللي ممكن نطبق عليها البرنسبل اللي أخذناه اليوم. For selection the most appropriate medications. الله يعطيكم العافية وشكرا لكم جميعا.
يعطيك العافية دكتور تامر. السلام عليكم. الصوت واضح؟ بسم الله والصلاة والسلام على رسول الله. First of all, I want to thank all of the members of this workshop, the organizing persons in the organizing company, our team in the education and the training department and the MHC Tabuk, and also want to thank my colleagues, Dr. Nashmiya and Dr. Tamer Nazi. Dr. Tamer for his clear, specific, and detailed talk about the antibiotics. Now we will transform from about the talking about the antibiotic, we will talk about the organisms. As you know, the organisms from the development of the antibiotics in the beginning of the last century, the microbiologists find that there is a group of antibiotics developing resistant to the available antibiotics. Your speaker is Dr. Atif Rahil, microbiology consultant, associate professor of microbiology and immunology. We will talk in this brief talk about the definitions and mechanisms of the multi-drug resistant organisms. Our objective is to revise the bacterial genetics, to define the different resistant mechanisms, and to discuss different resistant patterns. The upcoming activity and from 18 to 24 November, the World Antimicrobial Awareness Week, we are sharing the same activity in our hospital, inshallah, and we are doing this workshop in the same line. Why the antimicrobial awareness is a good practice now? Because we have a real problem about the antimicrobial drug resistance. According to the WHO, the expectations in 2050 that the antimicrobial resistance will be the leading cause of death according to all causes of death. As you see in this diagram, this is an official diagram of the WHO expectations. The antimicrobial resistance, and when we say antimicrobial, as Dr. Tamer previously said, we have different groups in these antimicrobials. We have the antibiotics, which we treating the bacteria. We have the antivirals, which we are treating by them the viruses. We have the antifungals, treating the fungi, the medical fungi. And we have the antiprotozoa. And the specific group of this antimicrobial resistance is the microbial resistant to the tuberculosis, which is out of this of the scope of this talk. The antimicrobials will be the leading cause of death in few years. It also a major cause of morbidity and mortality. And also it is a major problem from the financial aspect. It is expected that 1.2 trillion US dollars will be spent on the antimicrobial resistance problem by 2050. Now we will revise together the microbial genetics, the bacterial genetics. As you know, the bacteria is prokaryote, not eukaryotes. Prokaryotes is a primitive type of organisms. It have a cell wall, it have a cell membrane, have a genome inside it. What we are interested here is the genome of the bacteria. Each bacteria have a chromosome, one single chromosome in each bacteria. This chromosome is found in something called nucleoid, not nucleus, not surrounded by nuclear membrane. Some bacteria have another form of extra chromosomal genes called plasmids. Plasmids are circular genetic material present inside the bacteria. Why we are talking about the plasmids and the chromosome? Because the resistant mechanisms depends on these two items. As we will see, how the bacteria transfer the genome. We have different types of gene transfer between the bacteria. The first type is the conjugation. When a plasmid moves from the donor bacteria to the recipient bacteria, this form is called the conjugation. The second form is the transformation. When free DNA in the surrounding environment of the bacteria enter a specific type of bacteria, this DNA may be acquired from dead bacteria. This is called transformation. The another form is the transduction. This type is the transformation of the genome by viruses called bacteriophages. The bacteriophages are specific for each bacteria. Some bacteria have a specific bacteriophages, and these bacteriophages can transmit the genome between the donor and the recipient bacteria. The last one is a vesiduction. When the bacteria form a vesicle, and this vesicle exports the genome to another bacteria. This is how the bacteria can accept the genome and acquire a resistance. This will lead us to two types of resistance. We have intrinsic resistance and acquired resistance. The intrinsic resistance is present in approximately 99% of the wild type of the bacteria. The common type of a certain bacteria is called the wild type. And approximately 100% of this type will be intrinsic resistant to a certain antibiotic. The another type is the acquired type of the resistance. Acquired type, as from its name, it may be not found in a bacteria, but according to the surrounding condition, it will be acquired during the treatment time, or even during the bacterial life. The intrinsic type of the resistance is present usually on the chromosome, not present on the plasmid. But the acquired type of the bacteria present both on the chromosome and the plasmid. As you know, the plasmid, as we said before, the plasmid is mobile circular DNA. It can move from one bacteria to the other. The resistant genes of the acquired resistance are present on a certain area on the chromosome of the bacteria, not conservative area, in contrast to the intrinsic resistant usually present on a conservative area of the genome. The intrinsic resistance is fixed. This means that one bacteria cannot transfer the resistance gene to another bacteria because it's in conservative part in the chromosome. Not like the acquired one. The acquired one can be transferred between the bacteria, either found on the plasmid or found on the chromosome. Also, the bacteria resistance, the intrinsic type is stable. As I said before, the wild type of bacteria always have resistance to this antibiotic. Even this antibiotic test is susceptible in the lab. It is will be reported as resistant because it is the wild type resistant to this type. The acquired is changeable according to the course of the treatment. You may have certain bacteria susceptible to one antibiotic, and after time of the beginning of the treatment, you will find this bacteria changed to resistant one. These are the mechanisms of resistance, how the bacteria resist the antibiotics. Dr. Tamer said the mechanism of action and declared the mechanism of action of each group of antibiotics. Now we will see how the bacteria will resist these antibiotics. The intrinsic resistance usually due to the absence of the target. If the target is a cell wall, the cell wall deficient bacteria will be resistant to antibiotic working on the cell wall. Low affinity target. If the target have low affinity to the molecule, it will not be effective. Low permeability. If the antibiotic works on internal part like the DNA or the protein synthesis of the bacteria, and these bacteria have low permeability to this antibiotic, this antibiotic will not be effective. The efflux mechanisms, even the antibiotic entered inside the bacteria, some bacteria have a flux system to draw out the antibiotic. The acquired resistance, according to the two types, the mutation and the added genes. Mutation one example of it is the modification of the target. One of the most common types of the resistance is the methicillin resistance. As you know, they are working on a protein called the penicillin binding protein. Most of the cell wall inhibitors working on a protein called the penicillin binding protein. When this protein is modified, it will lead to resistance as the antibiotics working on this target will be ineffective. The added genes, it may lead to inactivation of the drug. It may lead to modification of the target, the 30 subunit or the 50 subunit. And the efflux mechanism is as the same in the intrinsic resistance. Definitions, we have groups of resistance according to the level of the resistance. The first definition is the MDR, the multi-drug resistant organism. This means this organism is non-susceptible to at least one agent in 3 or more categories. The categories mentioned before by Dr. Tamer, the penicillins, the cephalosporins, the carbapenems, the bonobactams, the macrolides, the aminoglycosides, the quinolones. These are called groups or categories of antibiotics. If this organism is non-susceptible, and non-susceptible here means it is intermediate or resistance to a certain antibiotic, one agent in the group. For 3 groups or more categories, this organism will be considered as multi-drug resistant organism. The more severe form of the resistance is the extreme drug resistance. This organism is non-susceptible to at least one agent in all but 2 or fewer categories. This means we have in all categories, but not 2, one agent is resistant or intermediate to this organism. The severest form of the drug resistance is a pan-drug resistant organisms. It is non-susceptible to all categories of antibiotics. And the definition of the pan-drug resistance is a definition of the reference lab. No peripheral lab or clinical laboratory by the available tools now can define a pan-drug resistant organism, because most of the diagnostic tools now cannot test all the available antibiotics of all the categories for this organism. And so it is a reserved definition for the reference labs only. Here we will talk about the organisms which have the drug resistance. We have the enterobacterales. The enterobacterales is a group of bacteria composed of some bacteria like the Enterobacteriaceae group, the Yersinia group, and the Morganellese group. The Enterobacteriaceae have some famous members like the Klebsiella, the Escherichia coli, the Citrobacter, the Enterobacter, and the Yersinia have also some famous members. One of them are growing up multi-drug resistant organism, the Serratia marcens, and the Morganellese have the Proteus and the Providentia and the Morganella. This group, the Enterobacterales, comprises the most isolated organisms in the hospital-acquired infections and the most resistant group. Here we will look for the intrinsic resistance figures about the Enterobacterales. As you see here, we have the organisms. As we see before, the Enterobacterales are a group of organisms, and these are the antibiotics. When we have an antibiotic resistant intrinsically resistant to, we have organism intrinsically resistant to antibiotic, this antibiotic will be removed from the categories for the definition of the MDR. This group will not be considered from the definition of the three previously mentioned groups. Here we see the first organisms, the Citrobacter fluoride. As you see, it is resistant to the ampicillin, intrinsic resistant to the ampicillin, also to the amoxicillin calvarinate, the augmentin, and the hypoetic. The ampicillin sulbactam, the unicin, is also resistant to the first generation cephalosporins. It is also resistant to the cefamycins, cefoxetine, and it is also resistant, intrinsically resistant to the second generation cephalosporins, cefoxetine. In this group, we have the Escherichia coli. The Escherichia coli, as you see, there is no intrinsic resistance in the to beta-lactam in this group. One of the most common organisms isolated in the hospitals is the Escherichia coli, and we are lucky that it has no intrinsic resistance. One of the most isolated organisms is also the Klebsiella pneumoniae, Klebsiella oxytoca. We have resistance to the ampicillin and the ticarcillin. The Morganella, also from the Enterobacterales group, is intrinsically resistant to many groups of antibiotics, like the ampicillin, the amoxicillin calvarinate, the first and second cephalosporins. It is also to the tigecycline, the nitrofurantoin, and for the polymyxin B and cholestyne. As you see here, all these groups will be removed from the definition of the groups of the bacteria MDR when we are looking for the definition. We will complete with Enterobacterales. Here we see the Salmonella and Shigella, and we are lucky also that these two aggressive organisms has no resistance to the beta-lactams. We have the Serratia marcinus, the upcoming organism. The rates of isolation of this organism is increasing among hospital-acquired infections, and many reports around the world are talking about the Serratia as one of the hospital-acquired infections. As you see, we have a multi-drug resistance according to the intrinsic resistance. And these groups will be removed also from the definition of the MDR when we are defining the MDR according to the previous definition. One thing we have here is the resistance to the polymyxin and cholesterol, as well as Morganella previously mentioned. This means if we have extended spectrum beta-lactamase or carbamidase resistant, the cholesterol will not be available as a choice for treatment. We have the Proteus, one of the most isolated also in the hospitals. It is also resistant only to the these groups of antibiotics, and especially for the nitrofurantoin. Proteus is known cause of urinary tract infection, and the nitrofurantoin is a known antibiotic for treatment of uncomplicated urinary tract infection, but for the Proteus mirabilis cases, it will not be available as a treatment option. Here are the groups for the antibiotics. Will we define on them the MDR? These are the groups: the penicillins, the cefemes, the carbapenems, the phenocols, the phosphomycins, the nitrofurans, the beta-lactam combination agents, the aminoglycosides, the tetracyclines, fluoroquinolones, monobactam, lipopeptides, and folate pathway antagonists. If any organism from the enterobacterial group is resistant to one antibiotic, in three of these categories will be defined as MDR. When we are revising the susceptibility report of an organism, we will look about the resistance. We are not caring about the number of the resistant antibiotics, but we are caring about which are these members are coming from. These are the groups, as you see, will be included in the diagnosis of MDR in Enterobacterales. There is a more concise definition for MDR in the Enterobacterales from the Ministry of Health guidelines. It says that any Escherichia coli, Klebsiella psittacia, Klebsiella pneumoniae, or Enterobacter species, these are only the 4 species listed in the definition. Testing resistant to imipenem, meropenem, doripenem, or ertapenem, any one of these, by standard susceptibility testing method or by molecular methods, will be considered as carbapenemase resistant Enterobacteres. Here we will see we have 4 antibiotics belonging to the to the carbapenem group, the imipenem, meropenem, doripenem, and ertapenem. If we have resistance to only one of these antibiotics and any of these organisms, by standard susceptibility methods. Susceptibility testing methods are standardized, even automated, FD approved, like the Phoenix, the Microscan, the Vitek 2, or by molecular methods by detection of the genes responsible for the resistance. If we have these 4 criteria, or 3 criteria maybe. If I have one organism of these resistant to one antibiotic of these antibiotics, either by the standard susceptibility method or by molecular method, this will be considered an carbapenemase resistant Enterobacteriaceae. And we will talk about the carbapenemase resistant more specifically in the another section today, inshallah. Another organism in this group, the Enterobacteriaceae, is the Klebsiella. The Klebsiella is one of the organisms isolated from the hospital environment and as a cause of hospital-acquired infection. If this testing non-susceptible means it is resistant or intermediate to one of these antibiotics, ceftazidime, cefotaxime, ceftriaxone, or cefepime. This will be considered cephalosporin-resistant Klebsiella. This is according to the definition of the Ministry of Health. Another definition for the multi-drug resistance and the Enterobacteriaceae is extended spectrum beta-lactamase. Any Enterobacteriaceae such as Escherichia coli, Klebsiella, and other gram-negative such as Pseudomonas aeruginosa. And recently, I think added to this group all the members of the Enterobacteriaceae and Enterobacterales like the Serratia. Resistant to these antibiotics, to penicillin, cephalosporins, and the monobactam group. This is because these organisms have enzymes. These enzymes will inactivate those antibiotics. We have finished the Enterobacteriaceae group. If anyone have any questions about the Enterobacterales group, because we will go to another group of bacteria. Any questions for this part of the talk? Now we will proceed to the second group of the organisms that have a multi-drug resistance. We will revise the intrinsic resistance in this group. We have the non-fermenter group, the non-glucose fermenter organisms. One of them is the Acinetobacter baumannii and the Pseudomonas aeruginosa, one of the most aggressive and one of the most prevalent organism from the hospital-acquired infections. We have also the Burkhardiria specia and the Stenotrophomonas multifila in the same group. Let's revise first the Pseudomonas. As you see, the Pseudomonas is intrinsically resistant to the ampicillin and amoxicillin, also resistant to ampicillin sulbactam, the unicin, and the amoxicillin calverinate, the augmentin. Also, they are intrinsically resistant to the cefotaxime, the ceftriaxone. They are also resistant, all these group are resistant to the ertapenem, one of the members of the carbapenem group. And according to this, the ertapenem will not be considered in the diagnosis of MDR if we are looking for a definition for the Acinetobacter, the Pseudomonas, or the other two organisms will not be considered as a carbapenem resistant, because these all this group are intrinsically resistant to the ertapenem. Also, we have here the Burkhardiria specia is resistant to the colistin. Back to the Pseudomonas, here we have the Pseudomonas are resistant, intrinsically resistant to the tetracyclines, the tigecycline, trimethoprim sulfamoxazole, cipitrin, the chloramphenicol and phospha and chloramphenicol. All of these antibiotics are resistant. Pseudomonas are resistant to them. If we are going to the Cyanidobacter, one of the most isolated organisms in the ICU units, we find it is also resistant to the ampicillin, amoxicillin, the amoxicillin calvolinate, the aztariunam, also the ertapenem, the trimethoprim, and the chloramphenicol and phosphomyce. If we looked here for the Stenotrophomonas multifilia, we will find that the Stenotrophomonas multifilia is intrinsically resistant actually to all antibiotic except for the ceftazidime, cefepime, and for the colistin, and for the trimethoprim sulfamoxazole, and also for the levofloxacin. According to this intrinsic resistant pattern, we will find that when we are defining a Cyanidobacter as a multi-drug resistant organism, we will define it according to these categories. We have these members only in the beta-lactam combination agents. We don't have penicillins here. Only these 5 antibiotics from the cefepime group. Only these 3 antibiotics from the carbapenems, the aminoglycosides, the monobactams, the lipopeptides, and the fluoroquinolones, tetracyclines, folate pathway antagonists, the trimethoprim sulfamoxazole. These are the categories. If we have 3 antibiotics in 3 categories of these categories, will we consider the Cyanidobacter as an MDR according to the universal definition. But according to the MHO definition, the MDR Cyanidobacter is defined as non-susceptible to at least 1 agent in at least 3 of these 6 groups: the penicillins, the aminoglycosides, the cephalosporins, the fluoroquinolones, the carbapenems, and the sulbactam. And I think this penicillin should be revised according, as we mentioned before, it is intrinsically resistant in the Cyanidobacter. We finished the Cyanidobacter. We will move to the Pseudomonas. These are the categories of the antibiotics will we consider in defining an MDR Pseudomonas. Only these antibiotics in the beta-lactam combination agents. And as we see here, we have the ceftazidime avibactam. I think it is available on the commercial susceptibility testing methods. Also, the piperacillin-tazobactam is available, but the ceftolazone tazobactam or the imipenem rilibactam is not available on the commercial methods now for diagnosis for susceptibility testing. And so we can't have a diagnosis in the common clinical laboratory labs for banned drug resistance. If we have 3 antibiotics in 3 categories of these categories for the Pseudomonas, this Pseudomonas would be considered multi-drug resistant Pseudomonas. The Ministry of Health definition: any Pseudomonas non-susceptible to at least 1 agent in at least 3 of 5 antimicrobial classes: the penicillin, aminoglycosides, cephalosporins, fluoroquinolones, and carbapenems. If we found Pseudomonas resistant to 3 antibiotics in 3 of these 5 antimicrobial categories, it will be considered multi-drug resistant Pseudomonas. This is example for the Pseudomonas for the definition of the bad drug resistance, extremely drug resistance, and the multi-drug resistant. Let's look for isolate number 3. As you see here, we have the isolate was resistant to imipenem, resistant to ceftazidime, and resistant to ciprofloxacin. Those are 3 antibiotics, but these 3 antibiotics are present in 3 different categories: the fluoroquinolones category, the cephalosporins category and the carbapenems categories. One antibiotic in 3 categories. This will be considered an MDR pseudomonas. But we have isolate 2 here. As you see, it is resistant to all categories except 2 categories. It's resistant to the gentamicin in the aminoglycoside category. It is resistant to all carbapenems. Also resistant to cefepime in the cephalosporins. It is not resistant to any of the phosphonic acids or the polymyxins. These are the conserved only conserved 2 groups. As we have only conserved 2 groups here, we will consider this isolate is extremely drug resistant. But to this isolate, the isolate number 1, we will find it is pan drug resistant because it is resistant to all available antibiotics. We will have finished the gram-negative bacteria. We will move now to the gram-positive bacteria. One of the most famous and the most known organism as the cause of hospital-acquired infection is the staphylococci. The staphylococci, staphylococci didn't have intrinsic resistance for any of the known antibiotics, and so all these categories are considered in the diagnosis of multi-drug resistant staph. We have after the staphylococcus, we have the enterococcus group. As you see, we have 4 members in the enterococcus group. We have the enterococcus faecalis, the enterococcus faecium, the enterococcus gallinarium, and the enterococcus cassiflavus. What I want to mention here that we have this intrinsic resistance to the vancomycin. The first 2 categories, the enterococcus faecalis and faecium, are not intrinsically resistant to the vancomycin. And when we are defining vancomycin resistant enterococci, we are not considering these 2 species in this category because they are intrinsically resistant to the vancomycin. So we can't consider an enterococcus species vancomycin resistant except after we know the subspecies. Here the groups will be considered in the diagnosis of MDR for enterococci. The highlighted, the gentamicin, streptomycins are intrinsically resistant to the enterococci. We are not using, if we are going back to the intrinsic resistance in this group, we will find that the aminoglycosides are intrinsically resistant to all enterococci, are intrinsically resistant to the aminoglycosides. Why we are considering the testing the aminoglycosides in this group? We are testing the high-level aminoglycosides testing for the synergetic effect with the penicillin or the ampicillin. If we have a high-level resistance, this means we will not have synergetic effect with the penicillin or ampicillin. We will not get benefit from using the aminoglycosides. If we didn't have this high-level resistance, it may be used as a combination drug with the penicillin and ampicillin, and we will get benefit from this synergism. These are the multi-drug resistant organisms priority according to the Kingdom of Saudi Arabia Ministry of Health. These priorities are listed according to the multifactorial issues. One of them, the mortality rate, the morbidity rate, and the prevalence. If we revise the MRSA, we will find the MRSA are more prevalent than the Acinido and the Pseudomonas, but the Acinido and the NICUs and the Pseudomonas are more aggressive and will cause more morbidities for the patient, and this is why it is listed here as a priority. We have the carbapenem-resistant Acinetobacter as a priority. We have the carbapenem-resistant Pseudomonas as a second priority. Also, the carbapenem-resistant Enterobacterales, any organism belonging to this group, testing non-susceptible to one of the carbapenems will be considered potentially carbapenemase producer and will be considered as a clinical priority. We have the extended spectrum beta-lactamase producing Enterobacterales. This is the critical group of the priority. We have the high group of the priority, the vancomycin enterococci, the VRE. We also have the methicillin-resistant Staphylococcus aureus, the MRSA, the vancomycin intermediate Staphylococcus aureus, the H. visa, and the vancomycin resistant Staphylococcus aureus. These are resistant organisms to treat, but it is very rare isolate. We have the new coming resistant types, the H. pylori when coming resistant to clarithromycin. It is considered as a high priority. If we have the Campylobacter orso, a fluoroquinolone resistant, the Salmonella, fluoroquinolone resistant Salmonella will be considered also a high priority. If we have Neisseria gonorrhea isolates, which is resistant to the fluoroquinolones, I think this will be a high group of the resistance. The least group is a medium group of priority. Streptococcus pneumoniae, penicillin or non-susceptible, Haemophilus influenza, ampicillin resistant, and the Shigella species fluoroquinolone resistance. We are about to finish this section. Resistance means less therapeutic options. Let's, for us, revise the groups of antibiotics mentioned by Dr. Tamer in the previous section. Here we have all these categories of the antibiotics. The categories, the red one, it is only active against the gram-negative bacteria, and it is not active against gram-positive bacteria. These in the violet color are not effective against gram-negative bacteria. They are only effective against gram-positive bacteria. And this makes some limitation in the treatment options. Let's revise now. If we are treating an enterobacterial organism, first of all, we will find that those two antibiotic groups are not effectively the penicillin or the first and second cephalosporins. For most of enterobacterials are not a usual susceptible antibiotics. And this removes those two groups of our therapeutic options. If we have this enterobacterial have the extended spectrum beta-lactamase enzyme, this means we will lose more than these categories. We will lose the penicillins, we will lose the cephalosporins with the third and fourth cephalosporins, and also we will lose the monobactams as therapeutic options. And if this excess beta-lactamase have the AMP-C type, it is a known type of resistance, we will lose those the penicillins, cephalosporins, and the monobactams. Also, we will lose the beta-lactam inhibitors like the augmentin. Also, we will lose the cefamycins from our therapeutic options. If we have this infection is from the urinary tract infection, this will be available for treatment, the nitrofurantoin and the phosphomycins, because they are used only for the urinary tract infection. If the patient is, we are talking about septicemia or pneumonia or something like this, we will, any other condition other than the urinary tract infection, we will not mention those two antibiotics as a therapeutic option, and they will be used. Also, if we have the patient is of the young age or pregnant women, we will lose the quinolones as a therapeutic option. And also, if we have the patient with urinary tract infection, we will lose the macrolides as a therapeutic option. And here we have the tetracyclines and the chloramphenicol. They are not usually used because of their severe side effects, as previously Dr. Tamer mentioned. Also, we have caution about using the aminoglycosides and the lipopeptides. The aminoglycosides are bacteriostatics, and they are not used alone as a treatment option. And also the lipopeptides, the colistin and the bromexin B, they are not also used as a single option of treatment. As you see, we still have only the folate inhibitors, and we only have the carbapenemase. If we have this organism have the carbapenemase enzyme, I think we will lose also the carbapenems as a therapeutic option. We will leave the gram-negative group and we will go to the gram-positive group. These are the antibiotics available for the treatment of gram-positive bacteria. If this gram-positive bacteria is staphylococci, we will, if this have the beta-lactamase producing staphylococci, and from our practice, from the statistical point of view, most of the staphylococci isolated from the hospital now are beta-lactamase producer. This beta-lactamase production will deprive us from a group of antibiotics, the penicillins, as the first option. We will lose the penicillin as a therapeutic option. If this beta-lactamase organism have a methicillin-resistant pattern, we will lose many groups of antibiotics. According to this, we are considering the MRSA, the methicillin-resistant Staph aureus, is a great issue in the infection control and in the MDR treating situations. If this staphylococci is methicillin resistant, this means it is resistant to the penicillin. It is also resistant to the first and second cephalosporins. It is also resistant to the third and fourth cephalosporins. Also, it is resistant to the carbapenems. Also, it is resistant to the beta-lactamase inhibitors, the augmentin and the inosine. And if this organism have another pattern of resistant beta-lactamase, methicillin-resistant, and mubrosine, lincosamide, streptogramine, we will lose another groups of antibiotics as a therapeutic option. We will lose the penicillin, we will lose the cefomycins, also the first and second, third and fourth cephalosporins, the carbapenems, the beta-lactamase inhibitors. Also, we will lose the clindamycin. Also, we will lose the macrolides if we are treating urinary tract infection. We will lose the daptomycin if we are treating a pneumonia case, because the daptomycin are not used in the respiratory infections. Also, if we are treating nitrofurantoin or the phosphomycins, only used in the urinary tract infections. And as you see, the same, the chloramifencol, the tetracyclines have severe adverse effects. They are only used in severe infections, and according to the condition of the patient and the cost-benefit issue. Also, we have the fusidic acid. It's only used as a topical application antibiotic, not used systematically. How we will prevent the multi-drug resistant emergence in a hospital? Many steps. The first of them is to raise awareness about the problem. We actually have a problem in developing resistant year after year. We have new resistant patterns. We have increase in the previous prevalence present organisms with multi-drug resistance with known drug resistant pattern. And we should raise the awareness about this problem. This is what we are doing now, and what we are doing in the awareness week, inshallah, in the last week in November. The prevention is best than the treatment, as you know. الوقاية خير من العلاج. It's better to follow the infection prevention control guidelines. In the era of the multi-drug resistance organisms, the infection prevention control guidelines, it is not just a quality, it's life-saving procedure. We should implement the antimicrobial stewardship policy in the hospitals, as Dr. Nashmia will talk more deep and specifically on the implementation of the antimicrobial stewardship tomorrow. And we should also have the standardized diagnostic to identify the bacteria and to identify the resistant pattern. The WHO have 4 priorities for the antimicrobial resistance. Priority 1 is stepping up leadership for the antimicrobial resistance response. Because without leadership, you can't go to any effective protocol or action. The second priority is driving public health impact in every country to address AMR. This is by awareness weeks and training and educational issues. This is to reduce the mortality and the morbidity, the disability, by reserving the effectiveness of antimicrobials by ensuring access to patient-centered public health services. The priority 3 is to the research, and to spend on the research, better to spend on the disaster. The research and the development for better access to quality AMR prevention and care. This is by promoting scientific interest, research, and investment into new tools and policies to decrease the antimicrobial resistance problem. The priority 4 is the monitoring the antimicrobial burden and the global AMR response. This is by to collect the comprehensive country-specific and the global data to monitor emergence and the spread of antimicrobial resistance drivers and the AMR response. This is by developing and strengthening surveillance systems and mechanisms for the collection, reporting, dissemination, and use of quality antimicrobial resistance data. I think by this, if we have finished, if any of you have some questions. I think we have some questions here. Someone asking about the responsibility of we have a question from one إذا كان resistant هل ينفع استخدمه أو لأ. Actually, if it is resistant, its use will not be effective. إذا استخدمت أنتيبيوتيك مضاد حيوي resistant لبكتيريا معينة لن تستفيد على الإطلاق ولن يستفيد المريض على الإطلاق. في سؤال عن مسؤولية قسم الجودة، مش فاهم السؤال صراحة. نحن نتكلم عن specifically عن المستشفيات، عن الهوسبيتال acquired infections، اللي ده الايشو اللي احنا مختصين بيه. الاي ام ار عموما مش مقتصر على المستشفيات، لان الديفلوبمنت اوف ريزيستنس يعني ظهور هذه البكتيريا المقاومه للمضادات الحيويه بيحصل على اكثر من مستوى. المستشفيات بتشارك بجزء نتيجه الاستخدام السيء للانتيبيوتكس، زي ما الدكتور تامر يعني اسلف في الذكر. الاستخدام غير الرشيد للمضادات الحيويه احد اسباب development of resistance، ده معروف في المستشفيات. لكن فعليا كميه الريزيستنت اللي موجوده على مستوى العالم ده نتيجه استخدام اساليب مختلفه. بعض الاماكن غير المملكه ما فيهاش ريستريكشنز على استخدام الانتيبيوتكس في الصيدليات العامه. يعني you can get the antibiotic from any place. ده جزء. في استخدام المضادات الحيويه في الصناعات الغذائيه، في مزارع، في مزارع الاسماك، في مزارع الدواجن، وحتى بتستخدم في الزراعات. يعني على المحاصيل الزراعيه بيتم استخدام الانتيبيوتكس، فده ادى الى ظهور هذا الجزء من الانتيبيوتكس. Responsibility of Infection Control Department in Hospitals, the MDR AMS ده بروجرام collaborative بروجرام، مسؤولية مشتركة ما بين قسم الصيدلية، قسم الانفكشن كنترول، والمختبر. وكل جزء من كل الاقسام المفترض ان هو بيتكون في المستشفى لجنه اللي هي الانتي مايكروبيال ستيوردشيب كوميتي، اعضاء منها في المختبر، اعضاء منها في الانفكشن كنترول، اعضاء منها في الصيدليه، اعضاء منها من الكادر الطبي وباداره الخدمات، واعضاء من الخدمات التمريضيه، واعضاء من الجوده، واعضاء من الاي تي يعني الانفورميشن تكنولوجي، عشان وضع السياسات. اظن ان احنا هنتكلم عن الكلام ده بالتفصيل ان شاء الله في الانتي مايكروبيال ستيوردشيب. الدكتوره نشميه غدا هتتكلم بالتفصيل على الانتي مايكروبيال ستيوردشيب ان ذا هوسبيتال. الكوليستين بيستخدم كمضاد حيوي في المالتي دراج ريزيستنت جرام نيجاتيف بكتيريا، لكن الريسنت ريسيرشز عليه بتقول ان هو لا يمكن استخدامه كسنجل اوبشن اوف تريتمنت، لازم يستخدم معاه حاجه ثانيه افكتيف. الفرق ما بين الانترنسيك ريزيستنت والاكواد ريزيستنت، زي ما احنا قلنا الانترنسيك ريزيستنت موجوده في البكتيريا، لم تكتسب، موجوده في البكتيريا في الكروموسوم بتاع البكتيريا، وبالتالي البكتيريا تحت اي ظروف هي مقاومه لهذا المضاد الحيوي. معظم البكتيريا 99% من، لو قلنا مثلا السودوموناس مقاومه للسيفوتاكسيم، فهنلاقي ان تقريبا 99.9% من كل السودوموناس مقاومه للسيفوتاكسيم. وحتى لو طلع السيفوتاكسيم سسبتبل في الاختبار المعملي، النتيجه لازم تنكتب ان هو ريزيستنت، لانه معروف انه مقاوم ولن يتغير. النوع الثاني اللي هو الاكوايرد، ده اكوايرد نتيجه ان هو موجود على البلازميد اللي هو بيتحرك من بكتيريا لبكتيريا، موجود على جزء من الكروموسوم، برضو الحركه فيه سهله. في تفاصيل في الجزئيه دي مش عايزين ندخل فيها، لكن يعني الفكرة العامة إن في جزء من الكروموسوم جينوم من المادة الوراثية اللي موجودة داخل البكتيريا تتحرك من بكتيريا إلى الأخرى، وهي بتتحرك بتاخد معها الجينات المسؤولة عن الريزيستنس، وبالتالي ممكن يكون في بكتيريا لا تقاوم المضاد الحيوي وتقابل في المستشفى في بيت المستشفى بكتيريا تانية مقاومة للمضاد الحيوي وتكتسب منها هذا الجينوم. بالنسبة لدور الفارماسيست ان شاء الله الدكتور تامر هيتكلم في محاضرة سبيسيفيك عن دور الفارماسيست. ان شاء الله هناخد بريك لعند اظن احنا دلوقتي 7:15، ممكن 7:45 ان شاء الله، يعني بعد نص ساعة او حتى 7:35، تلت ساعة كفاية عشان الوقت. ان شاء الله 7:35 او 7:45 عشان برضو الناس تلحقت صلاة العشاء. نبدأ إن شاء الله بعد البريك، نبدأ 7:45 السكند بارت. هنتكلم إن شاء الله بالسبيسيفيك عن الريزيستنت باترن، عن الام ار اس اي، عن الفي ار اي، عن السي ار اي، وعن الاسبلز هنتكلم عنهم بالتفصيل، وعن البكتيريا المسببة لهم إن شاء الله. فهناخد بريك لمدة نص ساعة بإذن الله تعالى حتى إن شاء الله الساعة 7:45.
يعطيك العافية دكتور عاطف.
الله يحفظك.
والكم
إن شاء الله هنصلي العشاء إن شاء الله ونكمل بعد صلاة العشاء بإذن الله تعالى.
نور إن شاء الله.
إن شاء الله. شكرا. السلام عليكم.
وعليكم السلام.
محتاج بس شير الاكونت عشان افتح بتاع الاكونت التاني اللي هو الاسم الكامل. محتاج شير الشاشة بس يا جماعة على الاكونت التاني. حد من المضيفين يفتح الشير. السلام عليكم. عذرا على التأخير. هنبدأ بقى إن شاء الله الجزء الأخير من اليوم الأول. الجزء الأخير إن شاء الله هنتكلم فيه عن بالتفصيل عن multi drug resistant organisms وعن resistant batteries. احنا اتكلمنا في المحاضرة اللي فاتت generally، لكن هنبدأ نتكلم specific. الكلام هيكون أكتر موجه للمختبرات. هنتكلم And now we will talk about the carbapenem resistant and the extended spectrum beta lactamase organisms as a type of the multi-drug resistant organisms. Here we will revise the most important multi-drug gram-negative bacilli as an organism from the bacteriological aspect. We will discuss the carbapenem-resistant organisms, and we will discuss the extended spectrum beta lactamase organisms. صوت واضح؟ تمام، على بركة الله. بسم الله والصلاة والسلام على رسول الله. The multi-drug resistant gram-negative bacilli, as you know, the gram-negative bacilli are a great group of bacteria. It is divided by its effect on the glucose as fermenters to the glucose fermenters and glucose non-fermenters. The glucose fermenters are divided by their effect on the lactose for the lactose fermentation. To lactose fermenter and lactose non-fermenter. In the lactose fermenter group, we have the Klebsiella species, and we have the Escherichia coli. We will talk about the Klebsiella as one of the most isolated organisms in the hospitals. From the lactose non-fermenter group, we have the Serratia, growing up multi-drug resistant hospital acquired infection. Also, we have the Proteus. We will not talk about the Proteus or the Escherichia coli for the limited time. In the glucose non-fermenter group, we have the oxidase positive, the Pseudomonas. We will talk about the Pseudomonas. And in the oxidase negative group, we will talk about the Acinitu. Then we will talk about 4 organisms: the Klebsiella, the Pseudomonas, the Acinitu, and the Serratia as members of known gram-negative multi-drug resistant organisms. We will revise the Enterobacterales again. In the Enterobacterales, we have the Enterobacteriaceae, the Yersineaceae, and the Morganelliaceae. In the Enterobacteriaceae, we have the Klebsiella, the E. coli, the Citrobacter, and the Enterobacter. In the Yersineaceae, we have the Serratia marcinens. And the Morganelliaceae, we have the Proteus, the Providentia, and the Morganella. And the Pseudomonas and the Cyanobacter is not included in the Enterobacterales because Enterobacterales are all glucose fermenters, but the Pseudomonas and the Aciniobacter are glucose non-fermenters. And we are describing this group of organisms, the Acinitu, the Pseudomonas, the Stenotrophomonas, the Burkholderia. They are totally described as non-fermenters. The first one is the Klebsiella pneumoniae. The Klebsiella pneumoniae, as you see here, the gram stain of the Klebsiella pneumoniae, it is gram-negative bacilli, usually capsulated. On the agar, it is showing mucoid colonies, and also it is on the mechanical agar, it is lactose fermenter colonies, pink colonies. It have variable biochemical reactions. The most dominant character is the citrate utilization here and here. It is indole negative, but some of the Klebsiella group are indole positive, like the Klebsiella oxytube. This is for the laboratory aspect. Klebsiella is known to be isolated from different type of specimens in the bacteriology lab. It's isolated from the sputum, the pus may be a cause of septicemia and isolated from the blood samples. When we are revising the Klebsiella pneumoniae virulence factors, we are found the Klebsiella pneumoniae are divided to different types. We have the classical Klebsiella pneumoniae. We have the new emergent Klebsiella pneumoniae known as hypervirulent Klebsiella pneumoniae. And we have the multi-drug resistant hypervirulent Klebsiella pneumoniae. These hypervirulent Klebsiella pneumoniae has emerged in the last years, and many recent researches are present on it now. The classical Klebsiella pneumoniae is usually nosocomially associated. You will find the infection comes from the hospital. On the contrary of the hypervirulent Klebsiella pneumoniae, usually isolated from the community. The infection, community-acquired infection, not hospital-acquired. Here in the, according to the host, if we are looking for the classical Klebsiella pneumoniae, it usually comes in immunocompromised patient, but in the hypervirulent Klebsiella pneumoniae, we will find it infects healthy adults, and this is why it is important. It is acquired in the community and infects healthy adults. The geographic region, it is isolated all over the world, the classic Klebsiella pneumoniae. The hypervirulent primarily isolated in Southeast Asia, but now many reports tells that is isolated from different parts of the world. The infections site, usually urinary tract infection, pneumonia, bloodstream infection, and the polymicrobial site of infection. The hypervirulent Klebsiella pneumoniae also gives the same type of infections, but also give deep-seated abscesses. We have pyogenic liver abscess. It may cause meningitis. It may cause endophthalmitis. This is a severe eye infection. It's treated by inoculation of the eye. If failed, necrotizing fasciitis, usually monomicrobial at the site of the infection, not associated with other microbes. Metastasis uncommon. If there is infection in one part of the body, it is rarely metastasized to another part, but in the hypervirulent Klebsiella pneumoniae, you may find a deeply seated abdominal abscess, and it will metastasize to cause a brain abscess and meningitis, or may metastasize to the eye and cause endophthalmitis. The multi-drug hypervirulent Klebsiella pneumoniae is as hypervirulent Klebsiella pneumoniae plus it is multi-drug. The phenotypes, there is this discrimination clear between the hypervirulent Klebsiella pneumoniae and the classical Klebsiella pneumoniae in the lab. The hypervirulent Klebsiella pneumoniae are hypermucoid, hypermucoviscosity. And if we are doing the strength test, we will find the strength test is more than 5 millimeter in length. And contrary to the usual classical Klebsiella pneumoniae, we will find it is less than 5 millimeter. This test, the strength test, is easily tested done in the lab, but it is not so sensitive. Some types of the hypervirulent Klebsiella pneumoniae, like the multi-drug, are not hypermucoid, and some of the Klebsiella pneumoniae, a little percent of them, are hypermucoid. According to the serotype, here we have serotype K1, K79. In the hypervirulent Klebsiella pneumoniae, we have different serotypes. It is the same serotypes present in the hypervirulent multi-drug resistant, with a small difference. And there's some difference about the production of the siderophores. That the hypervirulent Klebsiella pneumoniae is more producer than the other classical Klebsiella pneumoniae. What are the Klebsiella pneumoniae disease cause? We said this before, but we want to revise. The classical Klebsiella pneumoniae, we will find it isolated from the blood because of bacteremia. It may cause also pneumonia. It may cause also surgical site infection. It may cause urinary tract infection. The Klebsiella pneumoniae may be isolated from the nose, may be isolated from the oral cavity, the GIT. It may be isolated as normal flora, especially when the colonization rate is small. But if you find in the oral cavity or the nose a high colonization rate, you should consider this. The hypervirulent Klebsiella pneumoniae causes bacteremia pneumonia, surgical site infection, urinary infection, plus it causes meningitis, it causes endophthalmitis, liver and splenic deep abscess, and soft tissue infection. The other marker of the hypervirulent Klebsiella pneumoniae is the skin colonization. The Klebsiella pneumoniae, the classic one, is not known as skin colonizer, but the recent reports talking about the hypervirulent Klebsiella pneumoniae mentioned that the Klebsiella pneumoniae hypervirulent type may colonize the skin as well as GIT and throat and nose. The second organism with us, the aggressive organism, the Pseudomonas aeruginosa. It is also gram-negative bacilli. It grows well on different media. It grows in blood agar. It may cause hemolysis. It may not cause hemolysis, may be hemolytic or non-hemolytic. It may produce pigment, either green pigment, we see the green pigment, the yellow pigment, the brown pigment, and sometimes black pigment. And sometimes it is not non-hemolytic and non-pigment producer. Sometimes it is also a mucoid, like this type. We find this mucoid colonies of the Pseudomonas aeruginosa. And also we find these types, non-mucoid colonies, the clear ones, and this silver-like texture of the Pseudomonas aeruginosa. It is hyper variable in their colony appearance. Pseudomonas aeruginosa is known as hospital-acquired infection. It is usually isolated from the burn units. If you have a burn unit, you should have Pseudomonas aeruginosa isolate. Also, the Pseudomonas aeruginosa is known to have resistance to the disinfectants. It may be isolated from the common disinfected betadine and bovidine iodine used in the disinfection in the hospitals. It may live in these disinfectants and multiply inside these infections, and these infections may be source of infection to other parts. The Klebsiella pneumoniae is virulent organism, have many virulence factors. It have capacity to evade the immune response by the elicitase and alkaline protease. They are antibiotic resistant by different mechanisms. They have cytotoxicity. They toxic to the host cells by production of biocyanine, type 3 secretory system, the exotoxin A. It also have the ability to form biofilm, and this makes them one of the most organisms associated with devices. It is a motile organism due to the flagellae and the type 4 villi. Also, it have iron scavenging ability by production of protease and siderophores. These have many virulent mechanisms. Klebsiella pneumoniae cause different types of infections. It may cause infection of the ear, the internal ear infection, may cause eye infection. It may cause CNS infections, abscesses, and meningitis, especially in post-operative and in shunt patients. It also causes bacteremia, it's one of the known. It causes endocarditis as well as skin infection. As we said before, the burn units is a common source for isolation of Pseudomonas aeruginosa. It causes urinary tract infection from uncomplicated cystitis to severe pyelonephritis. It also causes pneumonia, especially associated with ventilator-associated pneumonia, also called VAB. And it also causes musculoskeletal tissue surgical wound, especially in the orthopedic surgeries. The third organism with us today is Cyanidobacter pneumoniae. It is a common organism isolated from the ICU's unit. It is gram-negative bacilli or cocobacilli. Sometimes it may be mistaken for diplococci. Especially, it is a gram variable. Sometimes, as you see here, it stains well with the crystal violet and become blue in color, while others are red in color, pink, gram negative, and this gram positive. This hypervariability in the gram reaction and in the shape make the diagnosis on the slide level is problematic. It is a non-hemolytic, creamy white colonies. Also, the Cyanidobacter pneumoniae is multi-virulent organism, have different types of virulence factors. As you see here, the pilus, it is responsible for the biofilm formation and the cell attachment to the host, the bacterial attachment to the host. The type 6 secretory system is responsible for the biofilm formation, for the motility, and the gene transfer. Type 2 secretory system, export of also we have the OMP responsible for the apoptosis, the process of cell death, programmed cell death. The biofilm formation, these are decreasing the inflammatory response, and this is active flux of the chlorhexidine make the Cyanidobacter is resistant to the chlorhexidine. The Cyanidobacter as well as Pseudomonas may cause pneumonia, especially the VAB1. Both are for the cystic fibrosis patients. Maybe cause bacteremia, septicemia, urinary tract infection, colonization of the surgical site infection, one of the known causes of post-surgical infections. It may colonize the respiratory tract and may colonize also the skin. The last organism we will discuss here is Serratia marcinens. It is also a gram-negative bacilli. This Serratia is known by its pink coppery pigment. When grown in clear media, white media, we will see these pigment apparently on the colonies. and it takes this color when grown on the blood. The Serratia, we are interested it now because it is one of the organisms are not known as the hospital acquired infection cause for the previous years, but now it is considered as an emerging hospital acquired infection organism. The other thing known about the Serratia, it is known as the Merkelius bacteria because it infects the bread and gives the bread the red color, and they are calling it the bloody bread. Also, another thing known about this organism, its ability to contaminate the cleaning components like the soap and the shampoos and these detergents. Have the ability to colonize these, and these detergents may be source of infection in the hospital. The Serratia marcins have many virulence factors: the hemolysis, the biofilm formation, and the proteases. It can cause pneumonia, urinary tract infection, surgical site infection, and rarely cause meningitis and endocarditis. And now we have finished the description of the organisms. We will come back to the pattern of the resistant. The pattern of the resistant is if we specific description of resistant action. When it is present, it gives us an impression about the organism. We have the CRE, the definition here. This carbamidase resistant enterobacteriosis. We have the pattern, the carbapenem resistant Pseudomonas aeruginosa. We have the carbapenem resistant Acinetobacter baumannii. And we have the last pattern, the extended spectrum beta lactamase. We have some definitions here about the type of beta lactamases. We have 4 classes of beta lactamases from A to D. The first class, the inhibitor susceptible class. The second, the B, the metallo-beta lactamases. C, the inhibitor resistant beta lactamases. The AMP-C, this is known in the Acinetobacter, the Enterobacter, and the Serratia. This type is present in the Serratia, the AMP-C, and we will talk about this in the next slides. And we have the group D. Group D mainly from the extended spectrum beta lactamase. And these are the genes for the carbapenem resistant and the metallo-beta lactamase also. These genes for the carbapenem resistance, and detection of these genes will define a specific organism as carbapenem resistant without the antibiotic susceptibility testing by using the molecular methods. We have definition about the carbapenem resistant. We have the carbapenem resistance. This means that this organism is carbapenem resistant, whatever the mechanism. It is resistant to the carbapenemases, either by the susceptibility testing or by the molecular methods, but we are not saying what is the mechanism. It may be carbapenemase production or not, but in the second one here, we have the carbapenemase producer. Here we have carbapenemase producer. Carbapenem resistance maybe have carbapenem production or other mechanisms like a flux pump or something like this. But carbapenem producer, it means it produces carbapenemase, and this can be done by the susceptibility testing and by the molecular methods. When we are saying that the organism is carbapenem resistant, this means it is resistant to the penicillins, resistant to the CFIMs or the cephalosporins. It is resistant to carbapenems and resistant to beta lactamase inhibitors like augmentin and unicin. And this is what is we called about pattern. If we have a carbapenem resistant pattern, these all antibiotics will be excluded from the therapeutic options. After the carbapenem, we have what are the carbapenem resistant present in? It is present in the enterobacterales, present in the Pseudomonas aeruginosa, and the Acinetobacter baumannii complex. How to diagnose carbapenem resistant? There is different mechanisms to different tools to diagnose carbapenem resistant. The antibiotic susceptibility testing. This is done in the lab by the either by the disk diffusion method or by the commercial methods. And these commercial methods, if not have confirmatory tests, these carbapenem resistant should be confirmed by these two organisms, the modified carbapenemase inhibition method or the EDTA carbapenemase inhibition method. We have also another tool for the diagnosis is the detection of the carbapenem itself. It is colorimetric assay. And it detects, it calls a carba-NB test. This is a trademark for the colorimetric assay for the detection of carbapenems like this. It depending on the colorimetric change. The other method for detection for diagnosis carbapenem resistant is the detection of the genes, like the methods found on the Gene Expert and if the approved instruments, it may detect the gene from the start, the KBC gene, Klebsiella pneumoniae carbapenemase gene, the New Delhi gene, the VIM, the IMB, the OXA48. All these genes can be detected by molecular methods and diagnose carbapenem resistance without the need for susceptibility method. And these methods have the advantage of the short time. We are doing a screening policy for carbapenem resistant. These tests will be, the result will be available about 1 hour, and it may be used as a care of point test, bedside care test. It will give us this advantage. If we are depending on the susceptibility testing, I think the result will not be available before 48 to 72 hours. The extended spectrum beta lactamases, we have a group of enzymes. This group of enzymes present in the enterobacterales organisms, present in the Pseudomonas aeruginosa, also in the Acinetobacter baumannii present. At first was diagnosed in members of the enterobacterales, then the Pseudomonas, then the Acinetobacter. We have the induced AMP-C type of resistance. This enzyme have special character. When you are testing the organism for the first time, you will find the organism is susceptible to cephalosporins. And once the patient begin his treatment schedule, in about 2 to 3 days, these organisms will develop resistant to the cephalosporins, and this is why we recommend that if we isolated Citrobacter, Enterobacter, or Serratia, especially in severe infection, and the treating modality is by cephalosporins, we should reculture from the patient in the third day of beginning of the treatment because we may find it resistant. The extended spectrum beta lactamase may be diagnosed by the diminished susceptibility to the cefotaxime, ceftriaxone, ceftazidime, cefpodoxime, and aztreonam. And the confirmation test, which is the CLSI approved, the cephalosporin calvulonate combination test. This is done, most of the commercial automated methods depend on this test for the diagnosis of the SBIL. There's another method for diagnosis of SBIL, the chromatotic method, the rapid SBIL NP trademark, and also the detection of the genes, the TMMA1 gene and the SHV1 and the TXM gene. It is done by molecular method and have the same advantage of the molecular method for the carbapenemase detection. I think we have finished the first part now, and if anyone have any questions about the multi-drug resistant gram-negative, in 5 minutes to complete. Any questions now? السيفالوسبورين one of the beta lactam group. يعني السيفالوسبورينز اللي هم السيفيمز في بيتا لاكتاميز resistant cephalosporins اللي هم one of the سيفيمز اللي هم السيفامايسينز والسيفالوسبورينز are beta lactams. But I think we have answered. If we have another questions, maybe. If we didn't have another question, we will go to the second part. I think we should do this now. الصوت واضح؟ حد سامع الصوت ولا مش سامعين؟ هنبدأ الجزء الأخير في اليوم وسريع إن شاء الله. We will talk about the gram-positive multi-drug resistant organisms. Here is your speaker, Dr. Atif Rahil. We will talk now about the methicillin-resistant Staphylococcus aureus, the vancomycin-resistant pattern, and the inducible clindamycin-resistant pattern. These are the objectives, and we have these resistant patterns in the gram-positive bacteria. We have the methicillin-resistant Staph aureus, the vancomycin-resistant enterococci, the high-level aminoglycoside resistant and the enterococcus, and the inducible clindamycin resistance. We will revise. We have the Staphylococci group. The Staphylococci is classified to two groups: the coagulase positive Staphylococci, which is the main member of it is the Staphylococcus aureus, and the coagulase negative staph is a group of bacteria. All of them are coagulase negative, and they are said to be, in brief, we are told them cons. صوت واضح؟ مشكلة في الصوت أو في الشاشة؟ الشاشة شغالة ما تمام كويس؟ ستافيلوكوكس أوريوس.
لا دكتور عاطف الشاشة غير شغالة، في مربع أسود.
المربع الأسود محتاج نعمل إيه طيب عشان نرجع تاني؟ طيب نقفل ده ثواني. تمام كده؟ اشتغل كده الشاشة؟
أيوة تمام كده
تمام.
واضح الحين.
تمام. عندنا في زي ما قلنا في 4 patterns of resistance and the gram positive bacteria: the methicillin resistant Staph aureus, the vancomycin resistant enterococci, the high level aminoglycoside resistance, and the inducible clindamycin resistance. As we said before, we have the staphylococci group, the coagulase negative Staph aureus and the coagulase negative members. These are group of normal flora, and they are known as opportunistic organisms. They are normally flora, but in immunocompromised patient in a device inserted, it may be a causative agent for severe infection. We are talking now about the Staphylococcus aureus, the known member of this group. That is a gram-positive cocci arranged in grape-like arrangement. When cultivated on the blood, it is usually beta hemolytic organism. It may be also cultivated on the mannitol salt with the yellow-colored colonies. The virulence factors for the Staphylococcus aureus. Staphylococcus aureus secrete toxins. Great group of toxins are isolated from the Staph aureus: the toxic shock syndrome toxin, the enterotoxins causing the food poisoning, the exfoliative toxin, and the BVL toxin, the Bantam Valentine leukocidine toxin. Also, we have the cell wall component, the protein A, the peptidoglycans, and the teichoic acid. All of these are working as super antigens and causing septicemia-like manifestations in the like gram-negative in bloodstream infections. We have the enzymes, the catalase and the coagulase, as virulence factors. The Staphylococcus aureus causing different types of diseases. It may cause localized focal suppuration like the carbuncle or the furuncle, the skin infection, the non-skin infection, which is related to the hair follicles. It may cause invasive infections like bacteremia, pneumonia, endocarditis, and it may cause toxigenic diseases like the toxic shock syndrome caused by the toxic shock syndrome toxin, the scalded skin syndrome caused by the exfoliative toxin, and the food poisoning caused by the enterotoxins. We have 2 groups of Staphylococcus aureus. One is known as healthcare associated MRSA and the community acquired associated MRSA. They have different characters. This is usually isolated from the hospital, and this is usually isolated from the community. But in recent years, we have researches that these community-acquired strains invaded the hospital environment, and the community-acquired strains are now present in the hospital environment and causing hospital-acquired infections. The hospital-acquired infection usually multiple resistant, with beside being MRSA to have other resistant to gentamicins, to quinolones. We will find they are resistant. But the community acquired usually non-susceptible, non-multi-drug resistant is only resistant to the previous group we mentioned, the penicillins, the cephalosporins, the other beta-lactam group, but not to other groups of antibiotics. Also to have for the genetic, from the genetic aspect, there is something called the Staphylococcus chromosomal cassette, the MEC. It is usually the health-associated MRSA carries the type 1, 2, and 3. But the community-acquired carries type 4 and type 5 with small interventions. The most characteristic genetic element differentiating the community-acquired MRSA from the hospital-acquired MRSA is the presence of BVL gene, which is responsible for the bantam-vartine leukocidine toxin. The MRS resistant, the MRS resistant is not for the Staph aureus only, but also present in the coagulase negative staph. But the one we should consider in this talk is the MRSA, the methicillin resistant Staphylococcus aureus. And when we have methicillin resistant Staphylococcus epidermidis or methicillin resistant Staphylococcus capitis or hominus, it will not be treated like the MRSA, only if the patient is immunocompromised and it is known as a causative for the disease. What is meant by the organism is MRSA or MRS? This is a pattern of resistance. And this pattern says that it is resistant to penicillins, it is resistant to all cephemes, cephalosporins and cephomycins, except the newly discovered one, the ceftaroline. Only this antibiotic is active against the MRSA from the cephemes. It's also resistant to carbapenems, to meropenem and imipenem, and also resistant to beta-lactamase inhibitors like the augmentin and unicin. The diagnosis of MRSA, depending on the susceptibility in the lab, we are using either the oxacillin disc or the cefoxitin disc. We are not using the oxacillin disc for the Staphylococcus aureus. It may be used for the coagulase negative staph. We may use the oxacillin MIC for diagnosing the MRSA. The most recent use is cefoxitin disc. We have the chromogenic media. Chromogenic media, it is selective media, and it is differential media. It selects Staph aureus, and it differential the methicillin resistant from other methicillin sensitive Staphylococcus aureus. There are many manufactured types of these media. The other method of the diagnosis of the MRSA is the detection of the gene, the MEC-A gene or the MEC-C gene, and also it is found on machines like the Gene Expert, and as the same as the carbapenemase and the SBL detection in the screening policies and in the emergency situations. These methods give us the advantage of the saving the time. The result will be available in an hour, and also it may be used as a point of care test. The vancomycin resistant is present in the Staphylococcus aureus, called VRSA, and the H visa, the vancomycin intermediate Staphylococcus aureus, or more importantly, present in the Enterococcus group. The isolation of the vancomycin-resistant Staphylococcus aureus is very rare, but the most prevalent organism is Enterococcus, and we have, as I said before, we have two species of Enterococcus should be considered as vancomycin-resistant Enterococci, the Enterococcus faecalis and the Enterococcus faecium, because the other two species, the Gallinarium and the Cassili-flavus, both are intrinsically resistant to vancomycin. The Enterococci, classification of the Enterococci as before, the vancomycin intrinsic resistant in the Gallinarium and the Cassili-flavus, and the vancomycin intrinsically susceptible to vancomycin, the Escherichia coli and the Enterococcus faecium. The Enterococci is gram-positive cocci. It is usually diplococci or short strains, usually non-hemolytic on the blood agar, sometimes rare isolates of the Enterococci are beta hemolytic, and rare isolates are alpha hemolytic, but the most common types are the non-hemolytic type. From the biochemical reaction, we have the biloscreen fermentation. It's usually positive in the Enterococcus group, differentiating them from the other Streptococci. The variance factors of the Enterococcus, the enterococcal surface protein, the aggregation substance, cell wall components, lipotecoic acid and adhesins, enzymes like digitrinase, hyaluronidase, and cytolysin. The Enterococci is known as a common cause of the UTI. One of the most common causes for hospital-acquired urinary tract infection is the Enterococci. It also causes endocarditis, meningitis, and peritonitis. Spontaneous bacterial peritonitis is known as, to be caused by the Enterococci. The vancomycin resistant, how to diagnose that Enterococci is resistant to vancomycin by the susceptibility method. Resistant to vancomycin should be confirmed by the vancomycin agar screening test. And we can also find the molecular methods, detection of the VAN-A, VAN-B, and VAN-C genes. These are the known resistant patterns for the vancomycin. We also have the high-level aminoglycoside resistance. As we said before, the Enterococcus species are intrinsically resistant to the aminoglycosides. But we are using this test, the high-level detection of resistance, to test the synchronization and the synergistic effect between the penicillin, ampicillin, vancomycin, and the aminoglycosides. If the aminoglycoside have high-level resistance to gentamicin or streptomycin, done by the high concentration, about 500 micrograms, maybe we will not get benefit from the synergistic effect with penicillin, ampicillin, or vancomycin. Remember that the Enterococci are intrinsically resistant, and we are doing the test for high-level aminoglycosides to test the synergetic effect with the penicillin, ampicillin, and vancomycin. The inducible clindamycin resistant, this is the last pattern we have in the gram-positive. It's present in the Staphylococcus aureus, also present in the Streptococcus pneumoniae, and present also in the beta hemolytic Streptococci like the Streptococcus pyogenes and Streptococcus agalacti. This type, inducible, as we said in the AMP-C before, it means this type of resistance will not appear except in the presence of the antibiotic. we can detect it by the susceptibility. We find the organism susceptible to clindamycin but resistant to erythromycin. We are doing, as you see, the T test. We are putting the erythromycin beside the clindamycin test, and we are looking for the D-shaped zone of inhibition. If we have this D zone shape of inhibition, this means this test is positive. And this means that susceptible clindamycin should be reported as resistant, and it is not effective agent for therapeutic option, and should be omitted from other options. We can detect this by the molecular methods, detection of the ERM-A gene or the ERM-C gene. I think we have finished now. If anyone have any questions, we can we are ready to answer. تمام، الصوت واضح؟
أيوة، شكرا.
بالنسبة الأخ اللي بيسأل كيف نعرف من الجين؟ الجين عبارة عن مادة وراثية موجودة على البكتيريا. الصوت واضح؟ أنا صوتي واضح ولا نفس المشكلة؟ صوتي واضح؟
الآن الصوت واضح.
تمام. الأخ اللي سأل عن الجين، الجين موجود في البكتيريا زي ما احنا تحدثنا سابقا، ان الجين هو سبب الريزيستنت، وفي ممكن يكون الجين موجود في البكتيريا بس ما بقاش اكسبريسد، يعني ما بقاش ليه اثر واضح في ريزيستنت، وبالتالي نلاقي الجين موجود، ونلاقي لو عملنا اختبار في المعمل للمقاومه للريزيستنت فنجد ان هو سسبتبل. في الحاله دي بنعمل كونفرميشن للاختبارين، للموليكولار ميثود، وبنعمل كونفرميشن للسسبتبيليتي ميثود، ولو استمر الكونفليكت بنعتمد على الطريقه اللي هي مور سيف فور ذا بيشنت، نعتبر ان هو ريزيستنت، وخصوصا لو في other options of treatment ممكن نستخدمها، يعني طالما ما فيش مشكله. كان في حد سأل قبل كده عن الكوليستين هل موجود على الاجهزه في المحاضره السابقه، وانا معذره ما فهمتش السؤال. هو طبعا الكوليستين بيستخدم موجود على الميكروسكان بس، مش موجود على الفونكس ولا موجود على الفايتك، لان هو بيعتمد على طريقه البروث مايكرو دايلوشن كطريقه معتمده، لكن مش موجود على الفونكس ولا على الفايتك، موجود بس على الميكروسكان اختبار للكوليستين، او ممكن يتعمل مانوال في المعمل لو متاح بنفس الطريقه اللي هي البروث مايكرو دايلوشن اللي هي معتمده من السي ال اس اي. حد عنده اسئله تاني؟ انا تخصص مختبرات، انا استشاري مختبرات ومكافحه عدوى. لو حد عنده اي تساؤل الداتا موجوده عندكم. بكره ان شاء الله هنكمل اليوم الثاني، هتبدا الدكتوره نشميه ان شاء الله بالكلام عن الانتي ميكروبيال ستيوردشيب بالتفصيل، طريقه الامبريتيشن داخل المستشفى. هكمل انا ان شاء الله بالبريفنشن ميثودز فور ذا MDR، ازاي بنعمل سكريننج للمالتي دراج ريزيستنت اورجانيزمز، وازاي نستفيد من المالتي دراج ريزيستنت كير باندل. بعد كده ان شاء الله الدكتور تامر هيكمل على الرول اوف فارماسيست ان ذا انتي مايكروبيال ستيوردشيب، هيتكلم على انترفنشنز وهيذكر اليورين تراكت انفكشن كمثال، ولو في وقت ممكن يكون في اوبن ديسكشن ان شاء الله على بعض الحالات اللي هي examples of interventions للانتي مايكروبيال ستيوردشيب. بارك الله فيكم، ونراكم غدا ان شاء الله الساعة 3. السلام عليكم.
عليكم السلام.